Good morning, everybody, and welcome to the second day of THET's conference, in which we reflect on, in a post-COVID world, how collaboration can make a meaningful difference to healthcare across the globe. Just a few things to keep in mind during the session. It's a safe space. You should all feel very comfortable to share ideas and experiences. Could you please put feedback in the chat box and any questions for the speakers in the Q&A box? Hopefully you can see those tabs at the bottom. Any issues with connection, please click the HD button and go to lower bandwidth. And that's the most technical bit of advice you're going to get from me today. The session will be recorded, and then the slides and the session recordings will be made available for sharing, which is a great resource. So I hope that some of you were able to join yesterday. It was a very stimulating day for all, with some really quite wonderful presentations. The morning started with some really great keynote speeches from Richard Horton, the Honourable Saliva Masibo, Minister of Health in Zambia, and Ganima Manadaha, who brought perspective of a Nepalese nurse, which was very moving. We're also honoured to have those opening words from Dr. Tedros. So I hope you found yesterday stimulating and engaging. And it ended with some fascinating insights from the Wellcome Trust. We're very pleased they could join us. And they went through their new strategy, and our wonderful trustee, Rhoda, working out of Somaliland, gave a very compelling summary of the day. So today is Happy Friday. It's our second and concluding day. This morning starts with some equally exciting speakers. I'm very pleased to be joined by them. We have three women speakers. They each bring a very different perspective. Our first speaker, to whom I will hand over in a second, is Tikala Itaye, who will be speaking from Malawi. Welcome. Tikala is the Director of Global Movement Building at Women in Global Health. She's going to bring a very welcome global perspective, talking directly to the themes of the conference and looking at the work she's doing in advance to advance the rights of women and girls. Just before I hand over to you, I'll just introduce our other two speakers. Jill Knight has stepped in very kindly for Sue Tranker, who I'm sorry to say isn't very well, so we wish her best. And she's going to be talking about the great work to advance recognising the experts in our midst agenda. And she is herself one of those experts. And finally, Vanessa Carter, welcome to you also, will be giving a very personal testimony, speaking to an issue that's close to THET's heart, the silent pandemic of growing antimicrobial resistance. You will know that the Department of Health and THET are partnering on with the Commonwealth Pharmacists Association on antimicrobial resistance. And Vanessa is going to be talking about her very personal experience in this critical area. So some wonderful speakers. Looking forward to your contributions. Tikala, welcome, and I'm delighted to hand over to you as the first speaker. Good morning.
Thank you, Justice, and thank you for such a warm welcome. Colleagues, health professionals, and distinguished representatives from academia, civil society, government, private sector, and many other health partners. Such great pleasure to be here today at the Tropica Health and Education Trust Conference and to speak on what is surely a critical theme of our time: reframing health partnerships, diverse voices in a new era. We are part of a world with diverse voices, diverse cultures, diverse experiences. And it is within our diversity we can forge strong collaboration to overcome many of the health challenges that face us all. So we know that the COVID pandemic hit a grossly unequal world and has deepened inequality within and between countries, especially gender inequality. I feel this conference is an opportunity for all of us to recognize the inequalities in global health and to jointly work together to remodel health systems and health institutions that are founded on equity and gender transformative practices. Why equity and gender transformative practices? Because one, gender pay gap. Women account for 70% of the health workers globally, yet they remain clustered in lower status and lower paid jobs. A July 2022 report for Women in Global Health estimated at least 6 million women working unpaid and grossly underpaid in health systems. This unpaid work is especially prevalent in the community health workforce. Research by the Community Health Impact Coalition estimates that in Africa, for example, only 14% of community health workers are paid a salary for their work. Secondly, let's look at gender inequality in leadership. Even though women are the majority of health workers, they hold only 25% of decision making roles. This means that women who are experts in health systems, who know their communities, who know how to reach the most marginalized, are generally not at decision making tables. Women in Global Health co-authored a key World Health Organization policy report in this area, delivered by women, led by men, which shows the gender gaps in key leadership roles in global health. Additionally, 85% of national COVID task forces globally are comprised of men. And we have seen the impact on decision making because of that, where there have been funding cuts or reprioritization in women's health in many low middle income countries. Lastly, sexual exploitation, abuse, and harassment. Health workers are experiencing this, but it is considerably underreported, and there's a huge gap in data and research related to this, with no serious absence of data, especially in low middle income countries. According to the Journal of Occupational and Environmental Medicine, we have seen about 62% of 330,000 health workers across a range of countries report exposure to work related violence and harassment in a single year. This is alarming, and more needs to be done to address this. Women in Global platform that seeks to compile and document stories of sexual exploitation, abuse, and harassment to help drive change in policies and practices. And we invite you all to be a part of it. So the current picture I have just shared around these three critical issues, gender pay gap, gender inequality in leadership, sexual exploitation, abuse, and harassment in the health sector, is devastating for our chances of achieving universal health coverage. It is high time that you and I and we together change the gender bias and discrimination in health workforce and health sector broadly. This is not only a woman's agenda, but everyone's agenda if we truly want to build strong health systems and institutions that are inclusive and that prioritize on gender equality. Women in Global Health movement formed around the issues of gender equal leadership in global health. Our movement has grown and strengthened through the pandemic, and we have about 41 national and country chapter women networks across the world, the majority in low middle income countries. And we have truly seen the impact women have in building better and strong health systems and institutions. Together, let us establish a new social contract for women health workers. Let us reframe health partnerships that drive equity of women's leadership, safe and decent working conditions for health workers, equal pay, and prevention of sexual abuse, exploitation, violence, and harassment. Let us create a vision of a better, equal global health system that works for everybody, everywhere, including girls and women in the most marginalized rural communities. We need to stand together and work together. This is an opportunity to reframe health partnerships. Thank you.
Thank you very much, and I'm looking forward to coming back in the Q&A to explore some of those important themes. And obviously shocking that 70% of healthcare workers are women, and yet they are so underrepresented in decision making. So thank you for that opening and powerful presentation. I'm going to hand over to Jill, if you are there, Jill.
I am. Good morning, everybody. Hope you're all doing well in this. What is it, drizzly, cold morning here in Wales. I'm just going to share my slides and see how this goes. And I'm hoping somebody can let me know if you can see the slides. Yeah, you're all
We can
gone
see the
silent out
slides.
there. Excellent. Let me go from the beginning.
We can see the slides. Looking good.
Okay, excellent. So hopefully the slide that you can see right now shows just the Welsh NHS, the holding slide at the beginning. Is that correct?
That is correct.
Excellent. Now I just need to navigate something here, and we are good to go. Has the slide changed, by the way? No? Sorry, Justin. What can you see now?
You've now got a sort of text. You've now got a sort of text. You've got a
Okay,
sort of text.
apologies.
GCNMHO hub. The
Yeah.
something common.
Okay, back to the slideshow.
Back to the slideshow.
Okay.
There you go. Wales context.
Yeah, apologies. What it won't let me do is just I'm so sorry about this. Give me we're ahead of time though, so this is okay. Let me just get something. Apologies, colleagues, for this.
Kieran is saying. Kieran is suggesting he can share your slides.
Uh, yes, Kieran, please do. What it won't allow me do. Apologies. Um,
There you go. You've got Wales context up. You're up and running.
Okay, fantastic. Apologies all for this. So my name isn't Sue
No,
Tranca.
no.
Um, my name is Jill Knight, and I am a nursing officer who works with Sue Tranca in Welsh Government. I am so sorry. She was so looking forward to being with you here today. So if we can stay on the first slide, please. She was so looking forward to being with you today, but unfortunately came down really unwell yesterday. So I send her best wishes to you all. So, Borada, good morning. As I said, I am here covering for our chief nurse this morning. I've worked in government for about 4 years now, and my portfolio remit is around nursing workforce, regulation, digitalisation of documentation. So, I have a really varied role, and I work really closely with our NHS colleagues across Wales on implementation of the Nurse Staffing Act with some of our brilliant civil service colleagues. So I'm going to give you a little overview before we move on of the slides, a little overview of the role of our CNO, Sue Tranca, here in Wales, what she's responsible for, and the different positions. That'll just set the context nicely. If somebody can keep an eye on time and give me when I have a little 5-minute warning, please, that would be much appreciated. So the CNO in Wales is responsible at a national level for all professional matters relating to nursing and midwifery workforce. So, doing that, supporting achievement of the best health and care outcomes for the people of Wales. So, the CNO provides leadership and support for the professions in Wales, ensuring that the health service has effective professional leadership. Really important, as we know. So the CNO is supported by a team with a chief midwifery officer, Karen, and 5 of us as nursing officers, and we all have differing portfolio remits and a team of civil servant colleagues supporting us. So it's important to note that the CNO Wales has 2 key positions. So one is as the senior advisor to the government ministers, to the Director General, and to the other government officials. Now, that senior advisor role is on all matters relating to nursing and midwifery, education practice, and the other key role is as the Exec Director of Nursing for our NHS Wales. Now, our NHS Wales consists of 7 health boards, 3 trusts, and 2 special health authorities. So the CNO provides that expert professional advice on all matters nursing and midwifery, whilst also including our legislation. So specifically, we have a Nurse Staffing Wales Act legislation, and we have also policy responsibilities in relation to maternity, breastfeeding, quality and safety of care in the NHS, and women's health. Now, if we can move on to the next slide. So, the pandemic has, without a doubt, brought UK and Ireland CNOs together more closely. Um, what I want to do is highlight on this slide. So, we have actually nearly 4 times as many sheep in Wales as people, just to give you a little context of Wales. And our population is 3.1 million. It's home to the highest mountain in England and Wales. That's Mount Snowdon, which stands at 1,000, I think, 85 metres tall. And Wales has more castles per square kilometre than other countries in Europe. Now it's interesting because Scotland might contest that, but I have been confidently told that Wales has more castles per square kilometre. Now we have 2 official languages in Wales, so we have English and Welsh. And health is devolved here in Wales. So nursing regulation is not, but health is free at the point of contact through general taxation. So we provide our services here in Wales through 7 integrated university health boards, providing for the population in specific geographical areas. And we have 3 All Wales specialist trusts and then 2 special health authorities. We've about 91,000 staff working in our NHS in Wales, and the number of nursing and midwifery professionals who are registered to practice has grown year on year. So at the moment, according to our latest nursing and midwifery report, we have 38,200 on the NMC register with a Welsh address. And this is out of about 758,000 across the UK. So the number in Wales includes about 36,000. And that means that working in Wales, we've about 5% of the total registrant population from the UK, which reflects our population as well. Now, we've been in all graduate professions since 2003 for midwives and 2004 for nurses. And the reason I'm giving you this is we have a real keen focus on our data, on our numbers, on our population, on what we need to provide the care and support for our population. If we can move on to the next slide, we also have that care provided by not just the NHS, but recognising the input of the third sector organisations, the support from a workforce perspective with those, and from the independent sector. Now, we have a range of policies in Wales up on this slide. Now, the pressures brought about by COVID are having an ongoing impact on the health and care system in Wales, and they've highlighted fragilities within our historic workforce models. Now, this is against a backdrop of an already acknowledged global shortage of nursing staff and a higher vacancy rate than we're used to. Now, it's generally recognised that an evolution in our workforce models is needed for a variety of service models provided in Wales. And we have an organisation called HEIW, Health Education Improvement Wales, which is currently undertaking work to develop a national nursing workforce plan, which will describe that. We're clear that a shift to a more multidisciplinary approach to workforce planning is imperative to support that individualized person-centered care delivery for the future that we need. And we've already got some work happening in certain health boards around a team around the patient type model, which is a good example of this type of approach. So we are determined to address the underlying pressures and the issues of staff recruitment, retention, and effective workforce planning to ensure we can provide the right number of nurses and healthcare staff across our system to meet that need. Now, if we can please move on to the next slide. So I've mentioned our challenges are no different in Wales than they are across the UK. Um, we're really pleased to have recently appointed 2 professional secondees who will commence hopefully at the end of November for a year to undertake some scoping work around Band 4 roles in Wales, considering what we currently do and what the opportunities around delegation and potentially a registrant or a registered Band 4 role in Wales. We've also got 2 professional secondees who are over halfway through a project looking at career spanning support. So that's how we support new registrants in the form of preceptorship from the point of registration, and how that support continues throughout their career in nursing. So it's a career spanning support that we're looking at to support our nurses. Now, the CNO, she attended a WHO ENC 22 conference 2 weeks ago, and she talked about our shared and common perspective as outlined in the European roadmap to implement global strategic directions for nursing and midwifery. Now, this roadmap outlines a want for a long term political commitment to the nursing and midwifery workforce through having sustainable investments in 4 priority areas. So, if we can move on to the next slide, please. So, staffing is a priority for us, and in the sustainable investments across the 4 priority areas with the WHO global strategic directions, we're looking at strengthening nursing and midwifery education and training programs, optimizing nursing and midwifery practice to enable nurses and midwives to practice in safe, supportive environments, creating a fund attractive jobs to increase the availability and to promote senior leadership positions. Now, these align very well with the CNO priorities. So, both the CNO and I are members of the Government Chief Nursing Midwifery Officer Hub. So, that's the WHO European Region Coordinated Hub through Maggie Langens. Now, this has been in existence for about a year, and it provides an opportunity for government chief nurses and midwives and leaders across the networks to learn from each other, to take stock of the issues, the developments, the challenges, the progress in specific priority areas in nursing and midwifery as leadership, education, and service delivery, because we want to advance that regional roadmap to guide and implement the strategic directions for nursing. We also focus on different country experiences on national data planning, management, and monitoring of our nursing and midwifery workforce. So these connections are so important to us. Similar challenges with system pressures, workforce exist across. I mean, we particularly in Wales have an aging population, and we know we have a greater number of patients that will be presenting with more complex health needs over the coming years. We have to look, as I mentioned, at more multidisciplinary approaches to workforce planning to meet those health needs of our citizens. Our focus has to be on supporting registered nurses to do what only they are capable of doing. I mentioned a number of secondee positions that we currently have out, and I'm going to mention another really exciting opportunity working with THET that we're hopefully going to come into fruition next week. I want to mention before that, yesterday I was on a judging panel for Best Diversity and Inclusion Practice Employer Awards. These are UK awards. Now, there was some amazing work highlighted across the UK, where as well as improving knowledge and skills of our diverse workforce across the UK, they're looking to help create a more positive working culture and boost employee morale. I was so pleased to see a real focus on utilising the RES data across England to inform what the priorities are around recognising the disproportionate number of nurses and midwives from ethnic minority backgrounds in lower bands and what they're doing to promote cultural intelligence across organisations. Now, we don't currently collect that RES data in Wales, but that's something we're looking to do with our Anti Racist Wales Action Plan that was recently published. That's a priority for us. Can we move on to the next slide, please? So, workforce, as well as being our most important asset, is definitely our most important challenge. So, we have a lot of work around that retention, attraction, and recruitment in Cross Wales. So, we, for the first time last year, embarked on a Once for Wales ethical international recruitment, where we, through an organisation working with us in Wales on behalf of all NHS organisations, has been working on a consistent approach to that, supporting our international nurses as we welcome them to work in Wales. So we have recently, in the last 6 months, over a year period, I guess it will be, that we'll have welcomed over 400 international nurses through this Once for Wales recruitment. What we're looking to do now, having successfully done that, is ensure that we're doing all we can to promote, support, and develop our international nurses. It's so important that they come, they leave their countries, they support our NHS, and we do what we can to ensure their skills, their previous experience is recognised within our NHS or other sectors if that's where they choose to work. So attraction, recruitment, and retention is key for us to ensure that we've got a range of support for our nurses that train here and our nurses that we welcome from abroad. Can I go to the next slide, please? So I mentioned the hub and I've mentioned the commitments there. So if we can move on to the next slide, please. You're welcome to have these slides afterwards. So other opportunity that I hadn't mentioned was the partnership work that we have currently with THET, where we're interviewing next week for a diversity and inclusion manager to work with THET and us here in Wales to promote equality, diversity, and inclusion, working with our diaspora staff across Wales. So we're really excited about that. So interviews are happening Tuesday and Wednesday of next week. Um, we have our connections with Wales and Africa. I myself have a long-standing uh, relationship with our nurses in Uganda, having had support through Wales and Africa small grants on a volunteer, so outside of my substantive post, and have been involved in development of leadership programs for nurses working in cancer, palliative care, looking at communication skills, and have undertaken a number of projects over the last 25 years. And I know many of our colleagues in Wales have existing connections with different countries, different links, and they're so valuable to inform and support that professional connection that we have across, well, globally. So we also have the CNO, and we're hoping to build on this with the THET post that will hopefully commence soon following interviews. Build on networks and forums that we have in Wales. So we've been establishing forums in each organisation, and the CNO is really keen to pull that together into a national advisory forum for the chief nurse around the issues that and the challenges that our nurses are experiencing. So I think I'm going to pause there. Nobody's told me to stop, but my clock is telling me that I've run over my 15 minutes. Is that correct, Justin?
No, you're good actually, because anyway, if you've
We were
finished, is there anything else you'd like to say before you conclude?
Um, just we really value this partnership around global health. We're really things have moved forward. I think with the digitalization over the last couple of years with COVID, our worlds have all um, the opportunity to work across the world has been enhanced, and we really want to build on that. The CNO is really keen that we do more, that we work together, that we learn from each other, we share experiences, and we do what we can at pace to support and progress the professional nursing and midwifery workforce globally. So we're in a really exciting place, really exciting time, where workforce is a priority for the CNO, and we're just looking forward to working with you at THET and others on this. Thank you, Justin, and
Well,
thank you all.
Jill, thank you very much. And we are also very excited to be working with you with the Diversity Inclusion Manager, who will shortly be appointed, hopefully. And you've raised a number of interesting themes to explore: multidisciplinary working, the importance of investing in the nurse workforce globally, and of course the important topic of the diaspora and their important contribution. So I look forward to coming back to those themes, and thank you very much for your presentation. So I'm now very delighted to pass over to Vanessa Carter. Vanessa, are you there?
I'm here, yeah. Can you see me?
We can see you. So welcome, and I'm delighted to hand over to you.
Great. Thank you very much. So I'm just going to try and share my screen. Can you see my presentation?
We can see your presentation.
Okay.
It's a photograph.
Yes. Thank you very much. Okay, just let me know if I cut out or anything like that. So thank you so much for having me this morning. So what I'll be doing is sharing a personal experience and bringing in a little bit more about what this whole conference is based on. That really is about diverse voices and teamwork, multidisciplinary teams to manage health conditions. And so in my case, I will get to in a minute what happened to me, but it was imperative that everybody worked together. And at the end, everybody did come together, and I was able to overcome an issue that I didn't think that I would at that point in time. So this photo that you see right now on the screen is what I call, and it is my last photo at age 25 years old. And shortly after this, I ended up in a very severe car accident. So on the right-hand top side is what the car looked like. It was a City Golf. I was a passenger in the car. And on the bottom left-hand side was me trying to survive all the injuries that had happened to me at the time of the accident. I was resuscitated on the side of the road in Johannesburg twice, and eventually taken through to Charlotte Maxeke Johannesburg Academic Hospital and put into high care where I fought for my life. So the top left-hand corner photo is of Charlotte Maxeke Academic Hospital. It's a very well-known hospital in Johannesburg. It's in association with Wits University. And I always say that, I was born there. I was born there in 1978, and I was saved there in 2004. With a medical team that was just absolutely fantastic. They worked on me. So this was my list of injuries. I had a massive head injury and facial fractures. I had a broken nose, broken jaw, smashed right maxillary sinus, orbital blowout. I lost the right eye, so I'm obviously visually impaired now. And I had severe facial lacerations. I had a massive abdominal injury. This was caused by the seatbelt. What happened was I was just kind of sitting wrong in the car at the time, and the car didn't have any airbags. So it pulled on my stomach. It pulled the chair out of the floorboards, and my face smashed onto the dashboard. So I do get a lot of recurring, gastro problems because of that. I fought for my life a second time about 8 years after that, when I got an adhesive bowel obstruction. Also had a fractured pelvis, a neck injury, and a back injury. So to kind of go through my photos on the left-hand side, the recovery, which basically took me a year, before I could drive again, before I could kind of walk again because of all the injuries. The physical pain, you can imagine breaking all these bones in your face and so on was not an easy thing to get over. The woman in the left-hand side at the bottom, she was a hairdresser that had to basically take about 2 days to brush all the blood, the blood and the car parts out of my hair. She was based in Charlotte Maxeke, and she wouldn't quit. She wouldn't cut my hair. I said, shave it off, and she refused to. So following Charlotte Maxeke Hospital, I kind of had to figure out one of the most is, so even though I had the stomach injuries, one of the most complicated things to put back together like a puzzle was my face. And so I went through many surgeries. I went through a lot of time trying to figure out which type of super specialists I needed, which types of doctors I needed. I visited many of them. And I had prosthetics implanted because I needed a few to rebuild the bone structure. But basically, in my 6th year of doing that, in my 4th prosthetic, I developed an infection. My body started to reject this prosthetic. And I had never seen this before. So this is basically what it looked like at the time. And I went to the shop the one day. I came out. This was literally about 2 weeks after the surgery that I'd had. So the first surgery that I had at this point in time was an alloplastic implant that was implanted by a maxillofacial surgeon. And then a couple of weeks later, after I recovered, it was touch-up surgery because the adhesions had adhered to this alloplastic implant, and that was done by a plastic surgeon separately. And 2 weeks after the plastic surgeon worked on me, I developed this infection. And I got into my car, as I said, I pulled down the rear view mirror because I felt this moisture on my face. And this is what I saw. And I obviously just, went overboard. I freaked out. I said, what is going on? So I phoned the doctor's offices and they said to me, you potentially have an infection. Come in and let's see what we can do. So what happened was we did a debridement surgery, meaning that we cleaned the prosthetic, and we did a little bit of reconstructive surgery, meaning that the infection had eaten the skin away. So we needed to do the plastic surgery to reconstruct the damaged tissue at that point in time. But this kind of went on for months and months and months. So basically what happened was I would go get the surgery done, and 2 weeks later the infection would come back again. And I would think, it's fine. But then I'd go back again, get another surgery done, and the infection would come back again. And it kept reoccurring. And at the same time, my team of doctors, I had different doctors giving me differing opinions and also prescribing me antibiotics between all of them. So what would happen was I'd go to, for example, my GP, and my GP would say, I'm not too sure what this is, but, maybe make an appointment with your maxillofacial surgeon. And in the meantime, here's a course of antibiotics to try to control it. And then I'd go to my maxillofacial surgeon and he would say, the infection, the other dog, I don't think the infection's on the implant. I think, let me give you a 14-day course of antibiotics, but go see the plastic surgeon in the meantime. And of course, there are waiting times that you go see these other doctors. And then I get to the plastic surgeon, and the plastic surgeon would say, wow, there's so much tissue damage right now. Let's get you into surgery. Let's do a debridement. Let's do reconstructive surgery. Let's prescribe another course of antibiotics. And of course, prophylaxis, as you know, during the time of surgery. So as I say, this went on for 11 months. Super specialists, maxillofacial surgeon, ENT surgeon, ophthalmologist, all prescribing, all kind of giving me this differing advice, to eventually to the point where on the left-hand side, I call this photo my point of no return, because at this point in time, there was so much tissue damage to my face from this infection. They keep cutting away the infection, and I could hardly wear an eye. So basically, I just covered my face up. Had a little boy that I used to go fetch from school, and the kids were like, "What's wrong with your mom's face?" Cover it. I had to cover it up. The public couldn't see it. And so my last surgery that I went for after 11 months was with my ENT surgeon, and my plastic surgeon, who by then we had built up a very strong relationship, had said to me, Vanessa, I believe that infection is on this alloplastic implant. I'm going to be in the theatre next door to the ENT surgery that you're doing now again, sinus drainage. And if I pop in there and I see this infection is still on there, I'm removing it. And so I took him with a pinch of salt. I thought, well, I haven't given him any authority to do that. But lo and behold, when I woke up from this ENT surgery, this prosthetic had been removed. And so it kind of rang alarm bells for me, because during that 11 months, I was so unsure what was going on. To me, it was just, an infection, the doctors can control it and so on. I'd be quitting a course of antibiotics halfway, saying, let me go see another doctor. I'd be, just doing everything that was totally wrong on the patient's side, even sometimes double dosing with antibiotics because I didn't really know how they worked. But as I say, this rang alarm bells, and I said, let me just ask for the test, because I knew that the prosthetic had been sent into Lancet Laboratories for testing. And so I phoned them and I said, could you just, fax me, email me, back in 2012, this was now, a copy of that test. And they did. And so on the right-hand side, it kind of lists a bunch of R's and a bunch of S's. There are 5 S's, there are lots of R's, and a word at the top that said MRSA. And I thought to myself, whoa, okay, is this like a type of infection? And so obviously as a patient, hearing this for the first time, I started Googling it and eventually realized that this was also, it was antibiotic resistance, which I had never heard of at that point in time. And the more I read as well, the more I realized that the more antibiotics that were being prescribed to me, particularly because MRSA is methicillin-resistant Staphylococcus aureus. Staph aureus is a type of bacteria. Methicillin resistance is a type of antibiotic that it's resistant to, that I was now prone to. They wouldn't work for me anymore, basically. So once I realized this and once I understood this, I knew that my surgical decision making had to change. I had to, before I knew this, I would say, well, the doctors would fix it. I'll go for as many surgeries as possible. They'll eventually get it right. But it was then that I realized that that wasn't the case. I needed to be very careful. I needed to get proper advice before we went for any kind of surgical intervention and before I took any antibiotics unnecessarily. So on the left-hand side is a doctor that basically what happened was I was at my lowest point. Obviously, my face was looking like that, and I sat in my office chair that day and I said, you know what, start sending your medical record out to as many of the best doctors you can find on the internet. And Dr. Edward J. Catterson actually ended up answering me. He was from the face transplant unit at Brigham and Women's Hospital. He was a craniofacial surgeon, meaning he worked on both soft tissue and the bone. And he was quite renowned because this face transplant unit was obviously working with foreign, as soon as you put foreign objects to your face, they need to know exactly what's kind of going on. So his secretary offered me a Skype consultation, which back in 2012 was like unheard of because we're only starting to talk about telemedicine now, especially after COVID. So of course I said, yes, please, can you just give me some guidance so I can kind of shorten my journey to repairing my face. And so he did. 30 minutes he Skyped me. He told me that I needed to use as little foreign objects as possible, do what they call a zygomatic osteotomy. So the middle picture is the bone. An osteotomy means cutting the bone, not putting any artificial implants in, and realigning it. So I took that advice in Johannesburg and I started finding doctors that mimicked it. And so you'll see my multidisciplinary team on the right-hand side, which I was able to work with to do this particular surgery. So infection did reappear. And I normally say to people, can you imagine if I got it wrong the first time and I had to do 5, 6, 7 surgeries as I did back then? I was a very high-risk patient. One of my doctors, one of my professors, Professor Reineck, who was a world-renowned maxillofacial surgeon in Johannesburg, was now looking after me. And there was a whole lot of communication going on between us. For example, he'd say to me, if another doctor tries to prescribe you an antibiotic, tell them you're under my care, which doesn't happen generally. I mean, when you go to a GP, you go to a dentist, that kind of communication doesn't happen. But this was important because right now I was sitting in a position where I could lose my bone, lose my face. And it was so imperative that I not only, adhered to my antibiotics correctly, but also that the other doctors weren't prescribing antibiotics at the same time, that they understood
Vanessa, I thought it might just be me, but I think we've lost your audio, Vanessa. Vanessa, we've lost your audio. Vanessa, can you hear me? We've lost your audio. Right, we have a technical problem. So I think what we'll do is, I don't think Vanessa can hear me. She's still talking, but I think what I might do is, I don't know, is there a technical person on who can either let Vanessa know, or I'll start the Q&A? Okay. So what we'll do is we'll start the Q&A. I'm really sorry because we're having such moving testimony from Vanessa. So I'm going to start the Q&A. Can I just turn to some of the questions here? So Jill and Tikala, would you mind unmuting and unzooming and making your video
Camera's
available?
back on. Yeah.
And I'm going to go to the Q&A, and then hopefully we'll get Vanessa back on in a minute. So can I come first to a question? Tikala, are you on? It's all happening this morning
Yes,
because I can't see. So Jill, okay, great. So there's a question here from Ben. So you talked about the challenges of gender inequality and the statistics. Vanessa, I think Vanessa, can you hear me? Yeah. So I'm afraid we can't hear you, Vanessa. So we've gone to the Q&A. I don't know, might be an idea to leave and come back in again, if that's all right. If you try that, it's the reset button normally helps with these things. We can't hear you. So maybe if you left and rejoined. In the meantime, I'm just going to ask Tikala a question. There's also inequalities in race, which Jill talked about. So we face these profound inequalities in both access to healthcare and in the delivery of healthcare. What's your advice? How do we in the world, so to speak, get going in starting to turn around some of these inequalities?
Justin, just to clarify, I'm answering on the question, the gender inequality. Do you also want me to touch on race inequality? But I think that's probably Jill's question.
Yes, although I think the intersectionality of it is interesting for both you and Jill, as obviously we know there's quite an intersectional issue here.
Yeah, sure. So, I mean, I can just give a shot on answering questions specifically on issues on how do we address gender inequalities, especially among our communities and the different respective institutions and work that we do. I think the most important thing is to really examine the harmful gender norms and practices. With a lot of work I have done in the sector of issues of gender inequality or even race issues, you find that it starts off with just even having conversations, whether having conversations in your workspaces or having conversations in local communities to really understand what people's experiences have been. And from there, being able to examine what has been harmful and what should be done among all those kind of harmful gender norms, right? So, just speaking from a personal experience, I was in a community once in Malawi and we were talking about gender and harmful gender norms. And, one of the men in the crowd said something to me like, oh, I don't understand why you're the one talking. Shouldn't there be a man leading this conversation? women are not supposed to be the ones addressing us on these issues. So I was a bit taken back, but it made me realize that, sometimes when it comes to issues of gender, you are looking at gender practices and norms and culture practices that have been practiced for years, right? And if we want to achieve gender inequality, we really have to go back and have conversations of getting people to understand, okay, I've been practicing this and understanding gender in this certain way. How do I change that? It's really a mindset shift. And the starting point has been having these conversations in the workspaces, understanding what people's gender biases are, and understanding what people's privileges are, and privileges and power, and how those can also be detrimental in some of the work that we do in the communities that we serve. So I think starting off with those conversations, identifying harmful gender biases and practices, and then taking it from there to figure out how do we begin to transform that within our institutions and our communities. But this is not a once-off 2-day, 3 months campaign. This is like an ongoing long term, because you're changing mindsets, you're changing practices. And a lot of people, this is still something new. I think, especially coming from the African context, people see things as gender as a Western concept, but it's not. So having to even think through, how do I begin to have these conversations in local languages and local contexts, that people begin to understand what equality means, and equal standing, and having equal opportunities and equal resources in different spaces. So it really starts with just start having those conversations and hearing what people's experiences have been and trying to work through that.
Thank you very much. And I guess that's a long-term program, but your basic view is starting communities and start making it clear the inequalities are there and starting those conversations. So, Jill, is that a theme which is familiar to you? Obviously, you're sponsoring the Diversity Inclusion Manager, and I guess there is a degree of intersectionality of the different types of exclusion and disadvantage. Your perspectives on that intervention from Tikala there, and your own experience and programs, please.
Yeah, thanks, Takala. So we have a Nursing Now group. We've had this group in progress pre-COVID, and one of the priority themes and work happening within that group with the representatives from across organisations in Wales and across the independent and third sector professional input. And that's looking at equality and diversity, both from a gender perspective and from from any perspective. We know there's an issue. I think the time is now that we need to proactively do something. So we need to target, we need to be proactive, we need to listen, we need to ensure that people who across all our sectors, settings, and population have a means through which they can raise their issue. We need to support our workforce, and we do need to promote targeted professional support and development and leadership opportunities. One of the submissions, I mentioned the shortlisting yesterday, they'd identified, we know there's an issue, but it's important to identify and understand what the issue looks like to be able to articulate it. So one of the submissions talked about, this was an organisation, a health organisation in the UK. It had a workforce where nearly half, from a nursing perspective, were from an ethnic minority background, but less than, or it might have been just about 1% were at a band 8 and above. So they identified that, and they proactively were working to support and understand why, and ensure that our nurses from any background have opportunities, whether it's opportunities to support them with the application process, with communication and presenting themselves, interview process, or something else. What we know is many of these nurses, it's not an academic education background. Many of them will have a number of degrees, masters, or so it's something else. So we need to understand what and ensure that we provide the right support, the right development, and we're really encouraged and looking forward to the equality and diversity manager starting, because we see this as something that they will support us with moving forward. That, alongside the existing networks that we have a huge amount of experience in our system at the moment. And we need to ensure that we hear, we listen, and we proactively have an approach for the whole workforce to do something positive. And I'm sure we will. We are, and it's building more on that. And then ensuring we look at the results. So I want to see a difference. I want to see a difference in 6 months, in a year, and I want us to have a long-term plan. And I know that's what our CNO is working towards.
Jill, thank you. And some very common themes there, in particular, making sure we have action and measurable results. Vanessa, can you hear me? Are you there, Vanessa?
I'm here. Sorry about that. Yeah.
I'm so sorry we lost the end of your presentation, but it was an incredibly moving and important testimony, and you could tell by the reactions, if you saw them, the impact it had on the audience. A question for you: given the profound impact that antimicrobial resistance has had on you, do you sense that the world is taking this seriously enough, or has it not yet hit people's radar screens in the way it needs to?
Based on obviously I went through my AMR experience back in 2012. Actually between 2010 and 2012, 2013. So it was 3 years. But now we're talking 9 years ago. I started advocating 9 years ago, 2013 to now. And so I've seen the space kind of expand. And one of the reasons I think that has happened is because they had the high-level meeting at the UN in 2016. And then, all of a sudden there was more action on it. There was more people getting online. There were more pharmacists, more doctors and so on talking about it. But one of the biggest areas that are lacking is patient advocacy. It has expanded slightly, but they are important voices. And of course, politicians, I don't think they take it seriously enough. I mean, when you go into a store and you buy meat or whatever, a pack of steak, because of course AMR it's cost cutting. It's not just in human health, it's also in animal health. It's also in food and so on. Why isn't it the norm to pick up a pack of meat and to see, for example, the farming practices that have gone on? Have they been responsible? Do you know how many antimicrobials, antibiotics are going into your body and how that affects you? So no, we're still far from where we should be. But there are more voices emerging, but we need to work harder.
Thank you. And this point about patient advocacy, I think we'd all agree is an important one. And I guess ground roots movements are what change things. Tikala, are you there? Because I'd be interested in, as I'm sure everyone would, in your perspective on how patients themselves can make a difference. And in particular, when it comes to gender inequality, how far is patient advocacy and on that topic and their experiences making a difference or can make a difference?
Thanks, Justin. And just to say, Vanessa, good to have you back. And your personal story was just so moving. And, with the work with Women in Global Health, it's these personal stories that help us really gain that those key messages when it comes to advocacy. A lot of the work that we do is centered around advocacy, and I really believe that personal stories from patients themselves have been the ones that have created the key messages to bring before policymakers and decision makers to really understand the realities on the ground. In most institutions, or especially low middle income countries, there hasn't been a platform where patients can really raise their issues and their experiences. But even in other platforms, they've been spaces where even though these issues are raised, nothing has been done. And I think the key thing is, especially when it comes to patient advocacy, how can our different institutions that are working in these areas be able to take up these voices and these stories and to bring them before decision makers to actually do something when it comes to policy changes or institutional changes that need to be done, or even improving quality of care when it comes to these different issues. I think the second thing is also being able to be creating platforms where people are able to share these stories and something's being done. Because I think as someone who's coming from a legal background and coming from a country like Malawi, we do hear a lot about medical negligence and we do hear stories from different patients. But most of the time, cases are just backlogged and nothing is being done to hold health institutions accountable. And I think this is also where we need to come in to say, how do we strengthen accountability measures when it comes to patient care? How do we ensure that people's experiences, especially patients' experience, don't just stay as experiences, but actually inform policy change and practices change to ensure that there is quality care that each and every one of us deserves. So I think those are some of the key things that we need to be thinking and looking about, because there isn't enough accountability, there isn't enough stories that are informing change. And that's some of the work that we are trying to do, especially with the community health workers that we work with, really bringing out these realities and helping them inform policy change at national and global level.
Thank you very much. And I think the theme of patient stories, and we know how they can be very effective in changing policy. Jill, any reflections or examples indeed of patient advocacy or patient stories helping drive the agenda you've been talking about, please?
Absolutely. I mean, patient advocacy has got to be one of the most important roles that a nurse can play in care treatment that we provide. So, as advocates, we help patients assert their rights, secure their treatment that they need. It's fundamental and underpins all aspects of us as professionals and what we do. You know, uh, Advocating for patients when they either can't or don't know how to advocate themselves is just obvious, important for the obvious reasons. Patient stories, formulating those in digital stories, has been core to how our boards across institutions and organizations have been ensuring that the patient and the service user voice is core to all we do. So that's fairly, I don't want to say standard, but that's a really important part of how our boards function in Wales. Truly listen, have that patient story underpinning the start of a board meeting. I would say there's a lot more we can do. Our legislation in Wales underpins and supports that formalising of that patient's voice in all we do, and I think it's ensuring that we actually ensure that we have representation on all of our works and our boards and our programs, and we truly listen. So I would say yes, of course, it's core important. We're always looking at new ways to ensure the carers, the patient, the service user is heard, listened to, and underpins how we deliver our services in Wales.
Brilliant. Thank you very much. Can I move to another theme which is coming up in a lot of the questions around the international workforce or the diaspora? So everyone's identified how critical the healthcare workforce is to all of your stories. And also there's a global shortage of 8 to 10 million. And also that many countries like Wales and the UK are relying upon an international workforce or a diaspora that's under-recognised. So if I can just explore that theme, maybe just coming back to you initially, Jill, as you talked about it specifically, how do you think we can most celebrate the role of diaspora and make sure that it is a positive for both the recipient nation and the nations where they will hopefully return?
I think there's a lot we could do in this space. So I talked earlier about listening to our diaspora nurses. So there's a number of associations supporting, representing, and working with nurses from. So I think supporting. Uh, so, for instance, next week there is the British Indian Nursing Association conference. So it's supporting, being present, listening, and I guess action. So don't just be there, don't just listen, do something. So listen to what the challenges are, use those to inform what we're doing to support the workforce. So I talked about the CNO priorities around workforce. So I would say retention is key, attraction and recruitment into our registered and nursing support worker roles. I mean, we there's been a number of experiences over the years where we have individuals who've trained overseas and are working as support workers across the health and social care system. We need to identify those, not years later. We need to have our processes in place where, when we're appointing people into any role, we explore, listen, capture, understand their previous experience, qualifications, and use that to support and inform the positions that we employ people into. Where there's an opportunity for development, where there's an opportunity for registration in a professional capacity, we need to support people to do that. Um, we there's a lot more. There's a lot happening in looking into this across the UK in patches. So I think we need to come together and share that more. We're starting to do that. I talked about the shortlisting and the awards yesterday. So we need to have a platform where we can explore and put a spotlight on not just the winners, but all of the great work, because the themes are similar. So if the themes are similar, we need to learn from each other and not redo, and work with the
Thank you.
countries that these nurses and healthcare professionals are coming from. There's a number of earn, learn, return type schemes. So work together to support and enable those type of schemes if that's what professionals and individuals want to do.
Excellent, and it sounds inspiring and very action oriented. Vanessa, I don't know if you have experience of this particular topic, or if it was a theme in your long and difficult journey of care.
Yeah, I think that one of the biggest things for me is, from experience, I don't ever speak outside of my experience as a patient, but always is about with fragmented teams, communication, working together, and as I said as well in my presentation, this was one of the biggest things that brought together, that helped me overcome a very, very serious infection, and to get to a point where I could walk out again, and yeah, I think AMS, antimicrobial resistance, is a very difficult thing to overcome, but it is a One Health issue. It does it does need a multidisciplinary approach. So I think that's, diverse voices are a huge part of that. And it's the only way that we're going to deal with the issue, at the end of the day. So yeah.
Thank you. So thank you for that. So Tikala, taking actually two themes together. One is this theme of the diaspora and international workforce, but also the underlying theme of multidisciplinary teams and appropriate skill sets. Your reflections on those topics would be welcome, please.
Sure, Justin. I think, looking even at the issue of great resignation and migration as well when it comes to health workers, that's also been a really big global issue. I think one of the biggest reflection is to really think through the working conditions health workers are working in. And I know Jill was just touching on this earlier on, but once you really sit down and hear the experiences of health workers, whether it's health workers from diaspora, and allowing those experiences, like I mentioned earlier on, to really inform some of the change of the working conditions, the internal policies, and the working environment is really key. Of course, in very developed countries, this is something that usually happens where there is those conversations happening, and leadership will make changes that are needed to improve working conditions. But I think that we also need to reflect on the global inequalities, right? So in low middle income countries, you are dealing with low HR, right? Health workers are working overtime, there's shortage in staff. And when it comes to improving working conditions, it all requires resources. And, you know, when I was hearing Vanessa's story, it got me thinking how she had to go outside South Africa, right, to get that specialized care. And it's not the norm in a lot of low middle income countries where you can afford specialized care or you have specialized care. I think we always fall into this situation where we either have to go out to look for it in low middle income countries. And it really gets me thinking of how do we actually address that other side of the coin, right? Yes, we have the issue of health workers in the diaspora and improving work conditions, that end. But then when it comes to the multidisciplinary and having different specialized care, there's also that other side of the coin of, can countries afford this? Can patients afford this specialized care? You know, when it comes to improving working conditions that are there to ensure there is better care, is this feasible looking at the different economic standing of different low middle income countries? So it's a very complex issue, Justin, and I do agree that multidisciplinary is key, especially when it comes to the universal health coverage framework we're all trying to advance when it comes to ensuring quality care for patients. But you know, it costs money, right? And there's definitely a lot that needs to be done in low middle income countries to ensure that resources and funding are prioritizing on
Absolutely.
providing quality care.
Thank you very much. Well, we're coming to the end of the session. So I think there's been a fascinating session. We've had, I think what we've learned is the interconnection of these important topics. Gender inequality, a global theme, action required, race inequality and disadvantage in different nations, the issue of an international workforce, and probably at the heart of this, the role of patient advocacy to start turning around some of these topics. So thank you, Vanessa, for your moving contribution. Thank you, Jill, for your insights from the work in Wales and looking globally. And Tikala, thank you very much for your powerful global perspective. I'm sure everyone has very much appreciated your contributions. With that, there's a few questions remaining. I hope we've covered the general topics, and thank you to our audience for participating so fully. We have a break now for 15 minutes, but hopefully it's not a break from learning. We've got two presentations in the lounge, which is a lounge area you can go and see Judith Ellis, the former distinguished chair of THET, from whom I was honoured to take over, and Nigel Crifts talking about their books and their experiences in global health in an interconnected world. To our speakers, thank you again. It's been a pleasure to meet you all virtually, and we'll be looking forward to future sessions. Thank you, everybody.
Thank you.
Good morning, everyone. We'll just give it a minute or two to let a few other participants join, and then we can get started. Thank you. Good morning, everyone, and welcome to day 2 of this year's annual conference. My name is Kieran Barber. I'm the Digital Engagement Officer at THET, and I will be chairing and introducing today's breakout session on digital transformation in global health. So this is one of 3 breakouts running in parallel alongside this session. We also have a session on multi-sectoral working and one on diaspora contributions within global health and also within the NHS. So not to worry, both of those recordings will be available on the conference platform for you to catch up on later. And likewise, sessions that you may have missed earlier or yesterday are also available on the platform. So please feel free to go to the schedule on your breaks or after the conference completes, and you'll be able to access all of the recordings across the 2 days. So today's session, I'm glad to mention, is sponsored by Healthcare UK, but we'll hear more from Maddie a little bit later on Healthcare UK, DIT and their work in this area a little later. So this morning, I'm delighted to be joined by a host of speakers with a wealth of experience and knowledge in the use of digital health technologies. THET have been active in this space, more reactionary from COVID, and now looking to move into various aspects of digital health to improve outcomes and in course of our green agenda as well. So before we begin, hopefully everyone managed to have a look at the digital housekeeping slides earlier, but please do use the chat and the Q&A box to leave any questions for the speakers. We should have some time at the end to do a bit of a Q&A and gain some response from the experts. So just in the interest of time, let's begin. We will again run through some of the speakers in tandem, but just to start off, we'll be joined by Maddie Bosey, who's the Deputy Head of Healthcare and Digital Health at the Department of International Trade. Maddie has led the development of the DIT UK Digital 100, which is a selection of the brightest UK digital health organisations who are sharing their innovations internationally, especially in low and middle income countries. And DIT also support these organisations in partnership models as well. So Maddie will explain how the UK has supported technology development that maximises better delivery of healthcare and what we can share overseas from the UK, and examples of some of the UK organisations and supporting digital projects as well. So Maddie's also experienced working closely with the Indian healthcare system, so has experience in some of the projects which we've spoke about today and across the conference. So Maddie, pleased to hand over to yourself, and please do feel free to present. Thank you.
Thanks, Kieran, and I hope the audio and video are all running all right. So I'm going to just start presenting my slides, but let me just start by saying that it's such a delight to be here presenting on this conference. I've not done that before at THET, but of course heard so many good things about it. So let's see if I can get the slides going. Can you see them all right, Kieran? I'm assuming they're coming up fine.
Yeah, that's coming through. Thanks, Maddie.
Great. All right. So what I'm going to talk about a little bit today is what we do at Healthcare UK, specifically on digital health, how we approach promoting what the UK has to offer, and do a little bit of a deep dive into the Healthcare AI Catalyst project that we ran in India. So hopefully we'll be able to cover that off in the time that we have. So Healthcare UK is part of Department for International Trade, but it's a hybrid team in an effect, because we are funded also by the Department for Health and Social Care and NHS England. And that allows us, on one hand, to support the NHS and access the NHS leadership, but also allows us to work with the DIT network globally, that is embassies and consulates and high commissions and people who are focused on promoting British expertise in those markets, based in those embassies, consulates and high commissions. So a lot of our remit and a lot of our responsibility is on working with the NHS and supporting NHS organizations in building the capacity and capability to do international work. We also work with the private sector in certainly areas like digital health more than others. And the overall objective is common. We want to grow the UK's exports into international markets. And that involves working with government and private sector networks all around the world. So when it comes to digital health specifically, there are a number of challenges that we have to face when we try to explain and articulate the UK's offer. Part of it is it's such a fast changing and such a fragmented environment in the UK. There are new innovators coming up all the time. So what we did was we came up with the idea and we launched this last year. We call it the Digital Health Playbook. And effectively, it is a collection of the best innovators from the UK who are, first of all, committed to exports, and secondly, committed to working with us in these markets. So when we thought of classifying companies in the playbook, we gravitated towards 10 what we think are universal questions. So rather than saying here's a set of AI companies or here's a set of virtual reality companies or genomics companies, we wanted to orient our thinking in terms of the problems that we were trying to solve. And so if you look here, there are 10 questions that show up on the screen. Some of them are related to patients, some of them are related to how the system works better or how we can support professionals, healthcare professionals in doing a better job. But they are all questions that any healthcare system would ask when it comes to digital transformation or when it comes to any sort of progress or new initiatives. So when we apply that to the UK's supply side, you come up with a bit of a, I mean, I've just put this up for illustration purposes. But just to give you an idea, when you look at the picture on the slide right now, you have 100 companies on there. We are now in the process of launching the next version of the playbook, which actually launches next week. And that has nearly 200. So it's a pretty large set, but it's then a question of making sure that we are in a position to respond to demand from overseas that says we are looking for British expertise. And that can be quite sort of fragmented at individual specific opportunities, but it can also be in response to global challenges such as COVID-19. And if you look at what I've put on the slide now, that is in effect mapping out a patient pathway for COVID-19 and then saying what digital technologies can we provide in response to any health system in the world coming to us and asking for support. So that just gives you an idea of both overall what we do as Healthcare UK, but also specifically on digital, what we offer and how we offer it. So now I'm going to deep dive into the HAIC project, Healthcare AI Catalyst. Now, this is something we did in India. Back in 2018, India announced what was called the Ayushman Bharat project. It was an unprecedented announcement because it really took the government's promise on healthcare to its people to a new level. One of the major pillars of that project or that program was the introduction or the provision of 150,000 wellness centers, as they were called. Now, these wellness centers would be dotted around the country, and to service that network of centers, there's a cohort of about 1 million frontline healthcare workers that were already in place but growing. Now, I think it's well known to an extent that India has a shortage, as most countries do, of healthcare professionals, but that becomes particularly acute when you look at rural and semi-rural areas. So these frontline healthcare workers would fill that gap and provide community health-based services in their rural communities. Now, on a separate note, you also had government formulated standard treatment guidelines across a number of healthcare areas. We in this project focused on maternal and child health because the indicators there were of particular priority for the government, and there were a number of challenges, both including the capabilities of the frontline healthcare workers, but also some of the support that was available for patients and those workers. So the project, in effect, was aimed at using AI to fulfill some of those promises, to fill some of those gaps in provision of care, and to in the first instance, or in the kind of first phase, to use that premise to see if he could support UK companies who had the right technology in demonstrating the impact that the technology could have. We ran the project from the announcement that took place in 2018 to 2021. So we finished it last year, and we were hit by a number of challenges, not the least of which was COVID-19 as a global pandemic that stopped work on the ground for a number of months. We ran the project in collaboration with Niti Aayog, which is part of the government of India, and the project was led by Elsevier in partnership with Piramal Swasthya and Lady Hardinge Medical College, which was the academic evaluator. So the hypothesis was that if we were able to support the frontline healthcare workers that were already in place, use and give them an AI-based tool that would allow them, excuse me, that would allow them to use the standard treatment guidelines in a very sort of hands-on way at the front line, and that would then enable them to provide better standardized care, so more consistent level of care, a more personalized care when you allied that the standard treatment guidelines, the computerized standard treatment guidelines, with specific health record data for each patient, and that solution would then enable these workers to provide better triaging, better referrals, and by digitizing the patient pathway, it would enable better continuum of care by making the health data of a patient follow the patient through the system. The solution that we used was Elsevier's Arezzo, which was a core solution for the clinical decision support system. It built in the standard treatment guidelines, the Indian standard treatment guidelines, and it integrated with an existing app called Amrit, which was provided by Piramal. And the Amrit app had the health records, and Arezzo brought in the clinical decision support. And the combined solution was piloted over a period of 6 months. So the main steps in the implementation were around the initially the computerization of the treatment guidelines, and that wasn't a trivial task, because while you had the guidelines in text form, they had to be merged and harmonized across multiple guidelines. The content had to be translated not only to the local language, but actually the local dialect and local vernacular, as we call it. And each main role, so you had the frontline ASHA workers, as they're called, then you had the nurse midwives and the medical officers. So you had a number of different roles that were created within the system. There was initial testing done. There's a lot of training that had to be done with the frontline health workers. And with any technology project, the ability to take people along with you on this journey requires a lot of upfront communication, a lot of training, a lot of demonstration of benefits, and so on. And the deployment, the final phase of deployment was done across 6 months in multiple sites in Barij district, which is in UP state in the northeast of India. Now, this is a very simplistic, simplified set of points around implementation, but happy to discuss this in more detail if needed later on. Just in terms of, oops, sorry about that. I think I've skipped forward, so I'm just going to go back. Kieran, are the slides visible?
They've went off, Maddie, I'm afraid.
Okay, let me just bring them back on. I have a very sensitive keyboard, so it tends to run away with itself sometimes. Right. Is that visible?
Yes, coming through now.
Okay, so just to give you an example of outcomes. Now, if you ran this as a very long academic evaluation and we could measure some of the benefits over time, we would go into some of the more bigger impact related points, such as access to care and the quality of care that we could affect. But in the short span, we were able to measure some of the feedback from the frontline healthcare workers. How useful was it? And if you see the fact that 80% of them wanted to continue using it, then certainly that gives you an indicator of how useful they found it. In terms of intelligence from the frontline to the health system, there were certainly benefits that it was demonstrating in terms of how you could get a population health view down to a fairly detailed and granular level. But you could also get other information around adherence to treatment guidelines and overall the efficiency of this health system. So I think that's it from me for the presentation. I've put in a link at the end to the actual final report for the HAIC project if you want to go and have a look in more detail. But I'm going to stop sharing and hand back to Kira now. Thank you.
Thanks, Maddy. Yeah, a wonderful example of digital health innovation in India, and I think this is certainly a space in which the health partnership community can learn a lot from. We've had a lot of health partnerships who have been almost forced to adopt a higher use of technology due to COVID. And I think some of the feedback we received recently is now they're looking to undergo some of this transformation into improving the project outcomes and using technology to support that. So yes, if anyone has any questions about Healthcare UK, the Healthcare AI project, which Maddy presented on, or digital transformation in general, please feel free to use the chat or the Q&A box. Thank you, Maddy. So just moving on and conscious of time, we'll also be joined by Clara Rodriguez and Isabella Borges, who lead on the telehealth network of Minas Gerais in Brazil. They will describe the experience and developments of a Brazilian telemedicine project during COVID-19. This was a project, numerous tools were developed as part of a full-on system and made available to both health professionals and the general public. So some of the examples of technology used included a chatbot, I should say, apologies, for patient guidance, teleconsultation technology combined with telemonitoring systems and educational programs for health workers and patients as well. So this session has been pre-recorded because time difference in Brazil, but I appreciate Isabella and Clara have been able to join today, so they should be able to answer any questions you have in terms of the programme. But please do use the chat and the Q&A tool to leave any comments. So we'll just share the presentation now before handing over to Clara and Isabella for any additional comments.
Good morning, my name is Clara Oliveira and along with Isabella Borges, we are going to present the Telehealth Network of Minas Gerais and some of its main projects. Isabella and I are professors at Medical School of Universidade Federal de Minas Gerais and integrate the coordination team of this Telehealth Network. The Telehealth Network of Minas Gerais was created in 2005 through a partnership between 7 public universities. It's one of the largest public telehealth services in Latin America and offers activities in clinical support, teleeducation, and research. Among the clinical support activities, we offer different modalities of telediagnosis, teleconsultations with healthcare professionals from different fields, mHealth, and decision support system development. Moreover, we develop implementation, epidemiology, public health, big data, and machine learning researches. The teleelectrocardiography is our most important modality of telediagnosis, and since 2005 we have accumulated a great experience in this field. There are 3 to 5 cardiologists on duty each day, and the emergencies are analyzed in less than 10 minutes. Through a partnership with Brazilian Health Ministry, we offer this service for 1,340 municipalities located in 13 states of the country. From 2005 to now, we have performed more than 6.5 million tele-ECGs, and currently we perform around 4,000 ECGs a day. Considering that cardiovascular diseases are the main cause of death in Brazil, and due to the experience of our telehealth network in providing tele-ECG service, we are coordinating a program to support the myocardial infarction network in the country, in partnership with Health Ministry as well. The main goal of this project is to improve the healthcare before a hospital admission, mainly through deploying tele-ECG service in most part of the public ambulances and training the healthcare teams of these units. With this program, we aim to increase the pre-hospital fibrinolysis rates and ultimately to decrease myocardial infarction-related deaths. Our network succeeded in 2 previous experiences in this field, both in Minas Gerais. To the telehealth intervention proposed, it was possible to increase fibrinolysis rates and to decrease mortality rates. COVID-19 pandemic has brought great changes in economy, society, and healthcare. The need to avoid patient crowds in health services and offer alternative ways for patient assistance while preserving physical isolation and providing portable drives for quick adoption of telemedicine. In this context, our network developed a telehealth system to provide assessment for patients with respiratory symptoms and updated information about COVID-19 to the general population. This system is called TeleCovid and its operation since May 2020 in 2 Brazilian medium-sized municipalities and in a federal university. The system was built to work in 4 levels. User access is enabled via chatbot or through a local phone call that represents the level 1. That means the screening level. Level 2 represents the nursing staff, 3 the medical staff, and 5 the level 4 represents the telemonitoring service. The system enables teleconsultation, medical prescription and report, requests for diagnosed COVID-19 tests, and further documents, all of which can be easily downloaded by users. Since the beginning of telecovid operation, more than 108,000 teleconsultations were performed and more than 37,000 patients were accessed through the teleconsultation system. Among all the patients assessed, around 6% of them were advised to seek an on-site evaluation at a primary care center or an emergency department. That means that telecovid-19 has almost 94% of efficiency in avoiding face-to-face assistance. Finally, the economics evaluation of this teleconsultation service demonstrated that it leads to an incremental access to medical consultation rate of 35 to 52%, considering the current consumer budget for the service. The telehealth network of Minas Gerais, in partnership with the World Heart Federation, participated of a project to evaluate the cardiovascular effects of COVID-19. We provided the tele-ECG service for this research that include more than 5,000 patients in 23 countries. The results are about to be published and show that major ECG alterations and a heart rate above 120 are prognostic markers in patients with COVID-19.
The COVID-19 pandemic has also posed challenges to the management of non-communicable diseases. Therefore, in partnership with the Brazilian Ministry of Health, we developed a multimodal platform of telehealth tools to support primary health care in this scenario. Brazil has a large territory with an equal distribution of health care resources, and telehealth is a practical approach to support primary care team based in remote locations. At the same time, primary health care is developed with the highest degree of capillarity, working as closely as possible to patients' lives. Therefore, a significant concern during the conception of this multimodal platform was to preserve the fundamental principles of coordination and comprehensiveness of care, centralized on the primary healthcare team of the participating municipalities. So, teleconsultations with secondary care specialists should be offered in association with teleeducation strategies and communication tools to promote an excellent primary-secondary care interface and a collaborative practice. Also, implementing patient-centered solutions to encourage autonomy and self-management was identified as much needed to achieve comprehensive and quality assistance based on best practice. So, the telehealth platform that was developed consists of the following: a decision support system to improve control of hypertension and diabetes, a text messaging patient-centered intervention to promote health habits and therapeutic adherence, the most varied teleeducation materials, multi-professional mentoring groups, and teleconsultations in cardiology, endocrinology, nutrition, nursing, and physiotherapy. The platform proved feasible and has been offered in 36 municipalities and 413 primary healthcare units since 2021. The model allows excellent proximity between the primary healthcare team, users, and the team of specialists who work remotely in assistance and education activities. As a result, the primary health care offers more dynamic care with expanded access to specialists through telehealth tools. In another agreement with the Brazilian Ministry of Health, motivated by the COVID-19 pandemic, the telehealth network created a program to implement telespirometry in primary care. Chronic respiratory diseases, mainly asthma and COPD, are responsible for thousands of deaths and disability worldwide, and this number is even higher in low-middle-income countries, including Brazil. Unfortunately, most Brazilian cities with less than 50,000 inhabitants do not have an spirometry test, which is essential in diagnosing and following these patients. This initiative enabled the implementation of a telediagnosis system in spirometry in 101 Brazilian municipalities with less than 50,000 inhabitants. One of the fundamental steps for this initiative was training 100 primary healthcare technicians to perform the exam in a mixed method of distance learning and face-to-face activities. So far, we have 2,436 tests conducted by the primary healthcare team. These teams have shown an exciting learning curve. Currently, more than 70% of the tests are of good quality. The experience of managing a large-scale telehealth service in the last 17 years left some crucial learnings. First, telehealth is a valuable tool to increase access to healthcare, which is particularly important in countries with social and political discrepancies associated with the concentration of financial, human, and health services in large urban centers. In addition, telehealth can be essential in helping to qualify the human resources in healthcare, contributing to increasing the local problem-solving capacity. Another vital learning, as already demonstrated, is that telehealth is usually a cost-saving strategy, and it should be considered as an alternative to deliver care with quality and safety to the population. This information can be helpful to the managers to allocate better resources for healthcare services. In addition, it's important to remark that, in most situations, it's possible to provide a quality telehealth service using cheap and readily available technology, such as phone calls. In opposite of some initial concerns, we can build an adequate patient-provider rapport virtually through phone or video calls. And finally, integrating the telehealth service with the local managed team is essential to achieve better results, but it's not enough. It's fundamental to adapt the telehealth solution to local needs. For this, partnership and support from government bodies are essential. As main challenges, we can mention, in general, difficulties in achieving universal usability of some tools due to discrepancies in digital literacy and access to technological resources among the population of the same country. Also, sometimes it's challenging to implement disruptive routine changes in health services. Therefore, we must ensure that telehealth strategies do not produce health inequalities. So, the emergency of COVID-19 defined a fruitful moment for expanding telehealth uses and applications. The concomitant use of these tools is overcoming distances, offering health education and quality and scientifically based healthcare more dynamically, with apparent cost savings and reduced workload. Therefore, we wish telehealth services would continue to be part of the healthcare in public service in the medium and long term, becoming a permanent part of the available care resources. But, of course, it's impossible to do all this work without these partnerships and the support of the government and the local and global research funding agencies, and especially without such a large, robust, and dedicated team. Thank you very much for your time. It's a pleasure to be part of your conference.
Bella, thank you so much for a wonderful presentation and again for joining on the day. A number of health partnerships across the community have expressed interest in telemedicine projects, and we know a number of them are, including Cambridge Global Health, who are carrying out a telemedicine project in Myanmar, which we can share more details about. Thank you again, and please do leave any questions in the chat and Q&A. In the interest of time, I'll move on quickly. I'm glad today that we're finally joined by Emily McMullen from HAE. Emily is Senior Programme Manager at Health Education England and has a special interest in health education, especially health technology, especially in conflict areas across the globe and in LMICs. She spends much of her time working on global health partnerships, especially in resource poor areas where she's particularly involved in developing clinical services and the training of health workers specifically. And she has been a great support to THET for a while now. So, Emily, I'll pass over to you. Thank you.
Wonderful. Thanks, Kieran. Now, this is when I really hope that digital technology does not let me down, because I'm here to speak about the benefits of it. So I'm just going to share my screen. And Kieran, can you just let me know that you can see that?
Yeah, Emily, that's coming through.
Wonderful. Thank you. So morning, everybody. Last but not least, we have health education in England, and we're talking today about educating the future workforce. So as many of you will be aware, ultimately oh, sorry, Kieran, I don't seem to be able to click over. 2 seconds. Okay. It says I'm presenting, says I'm on screen. Kieran, does that?
No,
do you want to share?
Could you try maybe stopping then sharing again, if that's okay, Emily?
Yeah, will do. There we go. Okay, we on?
Yes, Emily.
Did that change? Did that change?
Yes, but you're not in presentation mode. But I think we can carry on. We can share your slides after if that's easier.
Yeah, that sounds good.
Thanks, Emily.
So I'll start again. So morning, everybody. I'm Emily McMullen. I'm here from Health Education England. Normally I have my colleague Richard with me, who's our technology advisor, but he is in the Philippines this week doing some interesting work for us, so he's excused. As many of you will know, and this will be a familiar statistic, The World Health Organization estimates that 18 million additional trained health workers will be required by 2030 to meet global targets of UHC and the SDGs. That was pre-COVID, pre-pandemic, and obviously since that point, we've been mindful that even more attrition of health workers and resources requirement have probably pushed that number higher and faster. We know that the future health workforce learner is evolving and developing. They need more flexibility in their working, they need more flexibility in their learning, and they need more ownership over their learning. Common challenges that we face across the globe, and obviously from ourselves within the UK, is not only less staff delivering healthcare, but also a lack of protected time, a shift in the profile of staff. So we have multi-generations now in the workplace working together and training together, rising costs of attendance, transportation, cost of living, alongside resource austerity and the global shocks that we've seen creating burnout within the healthcare workforce. So it's an interesting and quite challenging time to develop these kind of resources, but one that feels like it's fresh and ripe for development. So one of the things that we're really interested in is ultimately how technology can enhance what we do, both within the UK and within global partnerships. I'm particularly interested in that human adaptability and technology and where we can see that intersection. So who are we? We're Health Education England. We are part of the NHS and work with partners to plan, recruit, educate and train health workforce, but particularly we're the Global Health Directorate. So we work to strengthen health systems and services through national, institutional and individual knowledge exchange. We work on technical collaborations and also formal global learning opportunities for that health workforce. We're pretty widely spread. We work across the globe. The areas in blue are the areas that we're working with as country partners at the moment, but we do also have additional 140 countries where we're using e-integrity access, so a huge reach of the work that we do. We work with a number of different types of organisation, and you can see that on screen. So we work with the NHS staff themselves, with the coordinating bodies, with our university and NGO partners. We work on behalf of the UK government to try and strengthen strategic partnerships. We have a consortium of NHS providers that provide technical expertise and advice in this field. And we work with Ministry of Health, industry and philanthropy partners on developing educational technology ideas. More recently, we've been strengthening our relationships with the World Health Organization and the UN in the form of UNESCO. So I was going to talk to you today about a slightly different element, which is technology enhanced learning. So obviously, Maddie, Isabella and the team have spoken about different elements, and so we're trying to give you a bit of a breadth today. So technology enhanced learning, it's a range of services enabling and providing applications of learning technologies. Particularly, we're interested in today talking about simulation-based education, and I can talk a little bit more about that in a moment. It's ultimately an enabling function. What we're not suggesting is that technology is going to replace the way that we've traditionally done learning and development for healthcare workers. What we're suggesting is that technology can enhance, it can support, and it can build national and regional capabilities and capacity within the health workforce. So we're really interested in how this educational resource might strengthen not only the health workforce capacity, but capability as well. So one of the things that obviously for those who are based in the UK, you'll recognise most likely the kind of image on the right hand side. The Topple review was completed in 2018, published in 2019, before the COVID pandemic, looking at how can we use healthcare technology to improve and deliver on healthcare services nationally. And as I say, I've provided a link there for those who haven't seen it. It's really worth a look. It kind of talks about the range of activities that are existing, but also could be developed further. So everything from wearable technologies to AI, to the use of digital technologies for education and clinics. Obviously, was slightly prophetic in terms of what we were going to need to do as a healthcare workforce in the UK and more widely with the global pandemic. So the things that HEE currently has I'm not going to go into detail because we've got a limited time today, but if you're not familiar with the resources, it's worth having a look. We have 3 main TEL platforms, so the NHS Learning Hub, and then we have the e-learning for health. So if some of you have done your mandatory training in the UK, you'll recognise that term. And then on the right-hand side, digital learning solutions. And ultimately, what we're trying to do is provide a range of opportunities for people to interact with the digital space and to enhance their learning through that capacity. One of the more interesting things at the moment is the piloting of some more, I guess, exploratory and novel techniques. So virtual reality is something that forms part of a suite of work we call immersive technologies. And immersive technologies are primarily for us looking at simulated experiences that can complement the kind of in-person and theoretical learning for healthcare professionals. Frustratingly, I don't think the link is working on the next slide, but I just wanted to give you a bit of a signpost to the website here. If you look at Health Education's AHP VR360, what that's done is provide an experience of the day in the life of that healthcare professional, particularly obviously based in the UK NHS, but still interesting. What you can fundamentally do is follow that person through their day in a 360 content. So it's ideal if you have a virtual reality headset, but we know that's not necessarily possible for everybody. So what we would also say is that you can access relatively cheaply kind of Google Glass, Google Cardboards, and ultimately that for us is the best way for you to be able to experience it, but you can just use it on a smartphone. So check that one out, that's quite interesting. So this is the website, but I don't think, as I say, we're going to be able to open the link today. I'll try it. If not,
sorry to interrupt, but the slides aren't working, so I'm trying to share some of the links in the chat, so it's just yourself you can see just now.
Oh, my slides aren't working.
Yeah, unfortunately.
Ah, okay, sorry, I didn't realise that.
I've mentioned we'll share the slides after the presentation so everyone has access. Thanks.
Okay, no worries. Well, in that case, I was going to show you a lovely video of, let me just see if I can. Just checking, that one's not working?
That's working now, Emily, thanks.
Okay. Yeah, perfect. So apologies that it's not a full screen, but just so that I think it's important for you to see for yourself what we're talking about. So this is my colleague Richard, and he is wearing what we call a HoloLens, which is basically a set of goggles with some cameras over the front, and that is to enable him to offer a 360 experience to people who are watching what he's doing and provide immersive experiences for people in training. So let's just watch the video and then we can talk about it a bit later. Kieran, has that stopped?
Yes, it stopped, yeah. Emily, the video stopped, unfortunately, yeah.
Yeah, I apologise. Just trying to see. Sorry, I will have to continue without that. I'll see if I can come back and get that a bit later on. No, the whole thing has stopped. As I said, the joy of digital technologies in this context.
Sorry, Emily, just in the interest of time, if we want to move on, that would be fine. Thank you.
Yeah. Brilliant. Okay, so from the digital technologies, as I say, so hopefully for the immersive tech, we can talk about this a little bit later on, but we've been using the virtual reality technology to try and think about how we might share knowledge and experiences with people who might not be able to physically access the resources in person or might need more time to practice skill sets repetitively. So, for example, surgical experiences. Obviously, then we had the COVID-19 pandemic, and digital transformation was the key. And at the forefront of this was that the ELFH, so some of our additional resources on the e-learning for healthcare, were accessed in over 140 countries. So we were giving access to our e-learning for health globally. So over 140 countries requested access to the learning technologies, and particularly the mandatory training and COVID-19 pandemic training. In terms of the global partnerships, the implication that this has had for us has been obviously within the global health context, we're dealing with a much more complex system in terms of climate change, human security, global health security, the impact of conflict and significant resource deficits. So we are trying to think about how can we utilize these technologies to be able to not only meet our commitments to international partnership around health technology, but also health learning more broadly, but also think about how we might meet our requirements of net zero, so reducing carbon emissions, minimizing excess travel, minimizing consumables. So if you're doing, for example, a trauma triage practice, you're going to need a lot of consumables that are disposable. Ultimately, if you can do that virtually, you can use a virtual model, then you don't need those consumables. We're aiming to meet those net zero targets that's set by WHO and for us in the UK with the Greener NHS. And ultimately, there's cost saving implications. So, how can we be more efficient? How can we optimize that physical infrastructure? So, for example, our hospital buildings, our appointment slots, and then also how do we optimize ODA and other grant funding that is obviously slightly harder to access in the modern time. And then lastly, how do we strengthen the employee opportunities to access education? So how do we create more flexible services? How do we use this to retain staff with more innovative and interesting ways of learning? How do we use it to strengthen workforce access? So, i.e., remote support for people who potentially have protected characteristics, who are unable to get to work, to attend particular training, people with physical limitations. That means that they are not able to physically access the space that their training is happening in, women who are currently on maternity leave but want to still access that learning. And finally, that decolonization of global health. So what we're trying to do is ultimately think, how do we utilize the knowledge that we have, but also utilize the knowledge that our global partners have? And I'm very sorry that you can't see the slides, because I'd love to show you the pictures that we have right here, which is about the trauma care virtual reality pilot that we've been looking at in Uganda. So on the kind of global health decolonization agenda, something that was really striking for us was obviously in the UK, we felt that we had a really strong expertise in this space, the virtual reality particularly, and the e-learning for health. And we arrived in country in Kampala and went to the local university at Makerere University to meet a local team. And that local team have not only gone out and found their own funding, but they had also developed a virtual reality lab. They had also developed content for that virtual reality. They developed ed tech that they had written up. They had also promoted that both via conferencing, but also written it up as peer-reviewed journal articles. So I think it was a real kind of radical moment of us realizing that there was still a risk associated with assuming that we would bring technology to the region, as opposed to utilizing the in-country experiences and working with them to see how we could strengthen infrastructure in country, but together think about that mutual learning. So the Trauma Care virtual reality program is ultimately a response to the in-country request for strengthening of the emergency care pathways. And one of the things that we're really interested in thinking about is how we might use innovative and immersive technology to upskill communities in rural and urban areas using life-saving skills.
Okay. Okay, so good morning, everyone, and welcome to this session which is entitled Multi-Sectoral Working, Bringing the Global Health Community Together. And I'm going to be chairing this session. My name's David Phillips, and I'm a medical academic at the University of Southampton. And I've been working for some 10 to 15 years on NCDs in Ethiopia. And to help me see our way through this, it's my very great pleasure to welcome our three discussants and participants. Firstly, Victoria Hollertz, who is Head of Global Programs at the newly formed UK Health Security Agency. And she has had really wide experience of working with several ODA partner countries and also linking with many other government departments, public health departments in the UK, so knows her way around Whitehall. Secondly, is Rosie Mayston, who is lecturer in global health at the King's Global Health Institute, and her background is in anthropology and demography, and she's currently leading on many mental health and chronic disease programs in several low and middle income countries. And lastly, and I know he's not on the screen yet, but I think he's connecting, is Barnabas Yaboa, who is Director of Nursing and Midwifery at the Ministry of Health HQ in Ghana. And he's covers a massive experience, 21 years working in the government health sector, and has extensive experience and an amazing background of work which spans public health, clinical practice, quality improvement, patient safety, child health to nursing and midwifery. So welcome to our three speakers. Now, just a few words of introduction. When I was asked to chair this session, I thought, crumbs, multi-sectoral working, I don't know anything about this at all. What do I do? Well, I sat down and thought a little bit and thought, well, it's relevant to what all of us do. I've been working on NCDs in rural Ethiopia for several years, and the attempt to set up clinics in remote areas, and realize that this instantly involves lots of other people. We find that we can't get to places because we don't have transport or proper roads, and that leads you to start negotiating with the authorities responsible for the roads and transport. You then get to the clinic and find, oh dear, we don't have any drugs. We don't no drugs to treat NCDs. So you instantly start interacting with pharmacists and people who run the logistics of drug distribution. Then after several months, we find that there's a very low uptake in the community and people are defaulting, and you need to start interacting with community leaders, church or religious leaders, and that probably wasn't enough, so we needed to talk to the anthropologists and find out why people weren't coming to the clinic. Then we ran into problems with health extension workers who said, oh, there's far too much to do, we can't do this work. And we're then back to talking to the government and the local health authorities. So instantly one's into this notion of having to work together with many different types of people from different backgrounds to actually get things to work. However, doing this, we made lots and lots of mistakes, and there's clearly a lot of learning we all need to do. So I'm going to turn now to my, it's going to be two and I hope three discussants to help us to see the way through this. So I'm going to start off, I think I'll start off with Rosie, as she's on the top of the list here, and say, well, what's your sort of experience of this? How do you see multi-sectoral working, and how does it work for you? Rosie.
Thanks very much, David. Yeah, I mean, so I'm an academic. I'm an academic researcher. As David says, I have a mixed methods background, and for many years now, so for about 10 to 15 years, I've been working with various different partners in sub-Saharan Africa, but also in Latin America and India. Working really with different partners. So our core partnership is with other research institutions in these locations. But we've also been trying to draw in community partners as well as kind of working upwards. So trying to liaise with policymakers, because obviously our end goal as researchers is to have impact. And in order to have impact, you really need to have that that liaison and those links with policymakers as well as with communities. So that's kind of what it means to me. I can talk about some of the challenges. I mean, David's already alluded to some of those. I think the biggest kind of current challenge for me around all of this is how to do global health partnership in the context of kind of decolonization debates, really. So how do we manage this kind of the power, the kind of ecosystem that we find ourselves in? And I'll finish off these first comments with a question, really. And that question is, can these global health partnerships ever really be equal, given the broader kind of macroeconomic context and political context that we find ourselves in? That's the kind of thing that I spend quite a lot of time thinking about recently, based on my kind of experience of working in this kind of context, really.
Okay, thanks very much. I forgot to say in my introduction that if people want to ask questions, I'd really encourage you to do that. Can you put questions in the Q&A text box, and it on your screens it's the third button from the left. So if you press on that and do your question, and we really welcome any questions. So I'm going to pass the baton to Victoria. Victoria.
Thanks very much, David. And great to be here today. What better way to spend our Friday than at the THET conference, really? So thanks for inviting me to be part of the discussion. As was said at the beginning, I'm head of global programs at the newly formed UK HSA. That used to be Public Health England. So we are the National Public Health Institute in the country currently. I'm specifically responsible for working with various teams delivering UKHSA's global programs. And within those global programs, the work is framed around implementation of the international health regulations, which is a set of legal obligations, and actually includes one capacity around multi-sectoral working and coordination. So for me, multi-sectoral working is really, it's the foundation of our approach to how we deliver our global work. I would be lying if I said that it was an easy approach to apply. It absolutely isn't. And I think David outlined it really well in the beginning of the session, how, these dependencies exist everywhere across the health system in terms of how we address very complex public health needs together. So in the context of a THET conference, I suppose, I think partners who dial into this conference are quite well versed in institutional partnerships. So the kind of, how do we engage with our various counterparts? It almost feels like that's the easy bit. And then to deliver our work, we need that multi-sectoral approach. And that's where it gets a little bit more tricky. And maybe we'll get to talk about some of the challenges in more detail and get questions from the audience as well on that. So my work specifically, where we work with other countries, we have teams in Zambia, Ethiopia, Nigeria, and Pakistan, all working to support those multi-sectoral approaches in a health security context. So again, this dependency on working with people with various skills from different disciplines, it's incredibly important. My teams also include a deployable rapid support team that deploys in health outbreaks, which is primarily a team of epidemiologists, but a wide variety of data scientists. So again, that kind of need to work with different skill sets is really of key importance to this work.
Yeah, thanks, Victoria. I think Barnabas has joined us. So, Barnabas, are you online now? Anyway, I wanted to pick up.
On mute, Barnabas. If you just come off mute, you can.
Yes, okay, all right. One of the things that really sort of struck me yesterday, something that Richard Horton, editor of the Lancet, said, was that we're moving from a sort of way of working, which he called it trickle down, that you give the money to the medics, the scientists, the public health people, and it sort of trickles down to everyone else. And it's something that manifestly doesn't work any more than trickle down economics does. And I wanted to pick up on something that Rosie said about power relationships. And I think, multi-sectoral working, we've got to move to a new era where there's much more sort of equality and everyone matters. And I think some of us don't know how to do this because we've come from that sort of scientific medical background. We're used to sort of saying, well, we do think things work like this, and that's what people tend to follow. And I just wondered how you sort of see things as changing over the next few years, and there's to move to this sort of situation where everyone is working together in a much more equal sort of way. Barnabas, I think are you able to hear us now? I think we're having trouble with the connection. Anyway, Rosie or Victoria, I don't know. Do you want to take that up?
Well, I think that certainly the way I outlined the international health regulations as being a set of legal obligations that actually most member states have now committed to achieving, I think working in the right kind of policy context like that often sets us up better for working in equal partnerships as well. But there's no denying that setting out those principles of partnerships to create equal partnerships absolutely have to be considered from the very beginning of a partnership and a relationship. And I think it's something that inside UKHSA, we're certainly spending much more time on putting in place. And because we are a new organization, we also have the opportunity to embed that within our new strategies from the very beginning. So we're currently working on a health equity strategy as well that will be embedded across all the work we do. But it really is a mindset. So I think everyone needs to consider that as a healthy way of working and build it into the way that we design programs.
Okay, yes, thank you very much. We're getting lots of sort of comments in the comment box, so but people really appreciating this discussion. I mean, so one of the questions is, well, the challenge of ensuring achieving equality in global health partnerships, and this is from Louise McGrath. How might some of these insights into this be achieved? Can I put that to you?
So, David, I think we've been quite. So I can talk to this from a kind of perspective of, as I said, a kind of researcher to researcher perspective, but also kind of research institutions and how they work together. That's the kind of core of the partnerships I have experience of. And I think it requires really a lot of reflection on our part. And I know that sounds kind of quite woolly. I think we've been, in terms of how we I think it needs to be monitored. Equity needs to be reflected upon, discussed from the outset, as Victoria says. And then I think we need to kind of keep going back to open up this dialogue about, okay, so what does equity mean? I think we've been quite focused on kind of outcomes so far, so measuring equity in terms of outcomes, and I'm not quite sure that's going to get us to where we need to be. We need to see partnership building as a process and kind of reflect on that process. And I think as Northern partners, we need to look at our processes. So it's been quite in terms of research partnerships. People have looked at things like publications as outputs, grant leadership as outputs. I think those are kind of quite broad brush measures. And as I said, I think we need to look at the kind of more in-depth steps that actually lead to those outcomes. And I basically think we need to kind of open up a space for having really open conversations right from the start of the partnership. A couple of kind of references on this or papers. So a colleague of mine, Ababel Fakadu, has written a really nice paper about, he's calling it the maturity model of partnership, which kind of outlines several stages leading from a kind of exploratory stage to a mature stage of partnership. And he kind of outlines the things that constitute a good partnership at each of those kind of levels. The other thing, so a lot of people will have heard of the Essence framework, and I think moving on from that, because that is quite outcome focused, there's something called the equity tool for valuing global health partnerships, which comes from Canadian researchers. And I think that's a really, really useful approach in terms of supporting the kind of dialogue I'm talking about. I have to say the kind of some of the limitations of all of this is that a lot of this is coming out of from Northern partners, and we need to find a way of getting the Southern partners' perspectives on all of this.
Thanks very much. I think Barnabas, are you able to join us now? Can we hear you? I'm still not getting any sound from you. Oh, good morning. Sort of welcome from the UK. I've sort of introduced you a little bit earlier on, but I mean, it'd be good to hear from you about your thoughts as to how the sort of multi-sectoral working happens, actually on the ground.
I'm online.
Yeah. Oh,
yes.
I think we're having some
for the opportunity. Let me say that a multi-sectorial partnership is very, very key and very relevant. Please, can you hear me?
You're breaking up quite a lot.
Very relevant in our...
Yes, I don't know.
Yeah, in our current world.
Yes, I'm sorry, Bon, but I think you're breaking up too much. It's very difficult to hear you. I don't know if
so
Alex.
Okay, can you hear me now?
Yeah, that's okay there. Yes.
Can you hear me now?
Yeah.
Okay. So I'm trying to underscore the importance of multi-sectorial partnership under the SDG 17. In Ghana, we have taken this very seriously. And so when we were developing and revising our national health policy, one of the key determinants we look at is on partnership. Hitherto, we were not involving the ministries, departments, and agencies of other sectors. We were just doing health policy related to only the health sector. We have shifted from this paradigm this time, and during the revision process, we reach out to every ministry, department, and agency as far as the health policy development was concerned. We had engagement with each ministry that is very relevant to health in Ghana. We had engagement with Minister of Information. We had engagement with Minister of Agric. We have engagement with Minister of Trade. We have engagement with local government, and you can name it. All the ministry, we had engagement. We try to mop up what are the determinants of the ministry that affect health, and then we're able to map up specific areas that have some determinants on health. And so based on that, we came out with the national health policy, and the key objectives were also based on the outcome of the ministries. So we have a new paradigm in terms of looking at the health issues now. So we were able to come out and agree that the other ministry, these are the areas they will have to tackle going forward. And then we're going to measure it from their program of work. And so this was a classical example of multi-sectorial partnership. And I think it has helped us. We've been able to agree on some of the things that we have to do. And we set up a task force to monitor how each indicator in the health policy can be measured. And I can say that it has really helped the other agencies to appreciate the health in all policies concepts and the One Health approach. And that is the way to go now. So if you look at the social determinants of health, you can clearly see the majority of the issues are really not within the health space. Most of them are outside the health space. So it is important that we continue to engage other sectors of the economy or other sectors and other important areas that we can bring together in order to move forward. So in Ghana, that is one thing we've done. And in terms of AMR policy, also, Ghana was one of the first countries to come out with an AMR policy and strategic plan. And in fact, Ministry of Environment engagement with Ministry of Government, we were able to come together and then develop the AMR policy because of the effects of their other ministries. And this has really helped us to work together. And one typical example we did was to work with the Ministry of Agric to build capacity of the poultry farmers in terms of the production of eggs. It's a typical partnership we've done. Hitherto, we're not doing that. We left them to do their own thing. But because it has effect on the usage of antimicrobial drugs, we had to come in and then have that partnership. So I think locally, partnership in Ghana, we're taking it seriously and we are working on it. And I would like to say that moving forward as a world, a global world, we need to have a network of practice across country to country and then at such sub-regional levels. And I think that is the way Ghana is looking at it. So we have from our sub-national level, we trying to work together at the sub-national level in terms of partnership. So we are local level in order to work together. Then at the national level, we have a policy to work with. So this is what I would like to say in my opening remarks. Thank you.
Okay, thank you, Barnabas.
Over.
I mean, we got virtually all of that. There were a few interruptions, but you're obviously way ahead of us, and that's wonderful to hear what you're doing. Okay, there are lots and lots of questions coming, so I'm going to put those to the team. A really interesting comment from Beatrice Waddington is that language is an important part of what we do in ensuring how we talk about the word equity. And do you think we should be using different sorts of language when we're talking about this? And she particularly raises the issue of the term LMIC, low middle income country. Do we need to rethink our language when we're framing these concepts? Anyone take that on?
I've got a bit of a practical answer to the question, maybe in that this has actually posed a challenge for us in terms of how we deliver technical expertise that's often sourced from domestic agencies in this country. And the challenge in sort of making that available in a peer-to-peer approach with our counterparts internationally. That's how, it sounds like it should be an easy thing to do, to just sort of share the technical expertise, but actually it isn't, because often you get stuck on how, the devil's in the detail and the way the language is used. Often from the beginning of setting up a partnership fails to kind of set out that equal partnership. And often it is because we're tied into certain jargon in our kind of wider sector about talking about LMICs, for example. So I did post in response to the comment a language guide that Bond came up with. Bond is a NGO network in the UK, and it's really useful to kind of look at how we can describe or have a different narrative to our work. And at UKHSA, we actually have a decolonizing global health group, which we deliver in partnership with Health Education England. So we've had a huge interest in the group, actually. And the aim of the group is to work together so that when our domestic experts deploy to share their technical expertise, we're basically better prepared to sort of take on those partnerships and have that equal conversation from the beginning. So I think that's one approach that I know lots of other organizations are doing similar efforts internally, but that's something that seems to work really well for lots of organizations, and it's almost becoming an expectation that it should be happening.
Okay. Can you give some examples of how they suggest we should use language? I mean, it'd be good. You've put the Bond link in the
chat. So I think they're just describing, the reason why we use LMICs, for example, is primarily like a finance driven. It's to categorize countries in terms of whether they're eligible for overseas development assistance or not. So that's really the only reason. In every other aspect, to me, in my partnerships, in our global programs, a global partner, as in another country, it doesn't really matter which country it is. All countries, we work on the same basis with all the countries that we work with. So it just gives you some suggestions about how you can just use language that is a little bit equal.
Isn't it a bit slippery though? Because I mean, in my life, we've moved from developing countries to third world countries to LMICs. If that becomes unfashionable, we'll move to something else which will become unfashionable. So you're dealing with.
We have to stay with the times, David.
Yeah.
I suppose it's just, we have to we are ultimately a global community. So I think it's just, we have to everyone needs to be part of that journey and be able to use the same language. And again, it just is that, for me, the definition is that if I work for a National Public Health Institute in this country, that, if I develop a partnership with another National Public Health Institute, that is on equal terms. We are counterparts and equal partners.
Okay. I mean, any other thoughts about language?
So, I mean, language and kind of moving beyond language. So I was at a meeting recently where one of the issues raised was about the dominance of English, and how, all of the kind of discussions about partnership, the processes of partnership, the expectation is that they will be carried out in English. And that's really tricky, I think. And I think there's some things that we can potentially do about that. People are starting to have kind of translations of core materials and so on that can be shared in other languages. And I think we need to kind of invest a bit in that. I think moving a bit beyond language, I mean, some of the other barriers, clear barriers that have been raised in our kind of meetings and discussions about partnership, and this again relates primarily to the research community, but I'm sure extends beyond that, in terms of kind of inequities that are sort of built into our current system. There are issues with visas. So when we invite colleagues to come and speak at conferences in the global north, they can have funding and everything kind of facilitated and put in place, but then they can be denied visas at the last minute. That's clearly a major barrier to kind of dialogue and equity. Funders. So for us, kind of as researchers, gaining research funding is a major marker of prestige. It enables you to have some protected time, enables you to network with colleagues, enables you to do the research work. We in the global north, we have training, we have admin systems, we have close links with the Wellcome Trust, with all the major funders, and so clearly we are in a kind of prime position to take advantage of the funding opportunities in a way that our global south colleagues are not. We have protected time to do research, and these are some of the kind of key things that have come up for us in discussions. And you can argue that as researchers we can't, there's very little we can do about some of these things, but I think we do have a role in kind of highlighting, trying to influence government, trying to influence funders into changing the way they do things, to promote equity, because we really are in a very privileged position, and I think that dynamic we need to be working towards trying to shift that dynamic.
I think some of these things are actually extremely difficult. I mean, the thing you mentioned about visas, we've had terrible trouble with this, and you've got the British government giving grants to encourage relationships with LMICs and joint projects, and then the Home Office sort of denying people visas, and it's very, very difficult to get a sort of coherent approach to this when the response you get is, oh well, we're dealing with a financial crisis or whatever else. Can we sort of go back to Barnabas? And I've got a question for you, Barnabas, and this is from Alex Rutherford, saying, welcoming you, but saying, how do you think we should go about setting up multi-sectoral partnerships? How do we go about it, and how do we use our individual expertise to input on these projects? And I think this is aimed particularly at you.
Yeah. Hello.
Hello.
Okay, so thank you very much for the question. But before I go there, let me also say that language could be a barrier in multi-sectoral partnership. And at the same time, it also raises equity issues. You look at, for instance, when you take our sub-region in ECOWAS, for instance, we have French-speaking countries, we have English-speaking countries, and that has not been so smooth. I would say you find a lot of funding agencies who are skewed to going to, if they are French-speaking, more or less, they want to go to the French-speaking countries, or if they are non-French, they want to come to English-speaking countries. And that also creates like the earlier speaker said, we are the global village and we work together. We have common health challenges for which we have to work together, irrespective of the language. Yeah, in terms of setting up multi-sectorial partnership, I think one key thing we have to look at is the interest of each partner, and how we are able to map up or do a stakeholder mapping of the various partners. If you're able to do a stakeholder mapping, you'll be able to know their influence levels, you'll be able to know their interest areas, and then you go ahead to now engage the various specific stakeholders, and then you can begin to align your interests and be able to now agree on areas of the partnership. I think that is the start of the thing. If you understand people's interests and then you're able to align and then see their level of influence and their resource availability, and then you can align. And that is the beginning of setting up your multi-sectorial partnership. And then again, it is important to be ready to let certain things go. You know, sometimes you may have your interest, but it is not all your interest that must play in a multi-sectorial partnership.
Oh, sorry.
You have to be able to let go certain things that to align our various interests, our various objectives and priorities, and in terms of our mission and vision. Definitely the partnership will not work. And so for me, it is important we all understand each other's vision, our interest areas, the resources that is available, then we can align. And then the partnership can be more successful. Over. Thank you.
Yeah, yes. Thank you, Barnabas. I mean, there's some really important points there, and I think so much of my experience in Ethiopia has been that people got their little empire, and when you start trying to interact with them, it's a threat to them, and it's understanding these relationships with each other seem to be really important. And as an outsider, I have limited understanding of the way things work in these countries at a very deep sort of level. Rosie, you were going to say something. Sorry, I interrupted.
Yeah, no, it was just to agree with. We take a very similar approach to Barnabas in terms of mapping the different stakeholders and looking at the different pathways to impact and how you can kind of work with a kind of aligned interests, even though everybody has their own kind of quite disparate interests going on in the background. So we work in a very similar way. But I'd be interested to get Barnabas's thoughts on, and Alex had raised the question about community involvement, because I think obviously ostensibly what we are doing is to try to improve things for communities. But I think drawing them into this process of public health or public health orientated research is quite challenging, because they're so far removed. What we're trying to do is get that chain working between community and then researchers and then public health kind of managers and policymakers, and get that into a kind of iterative dialogue, I guess. But it's a really tricky cycle to get working well, I think, and it involves a lot of I think a lot of serendipity, in a sense of research interests aligning with what policymakers want to do at that particular time. But I don't think the priority setting is really where it should be, which is with communities. Because we often don't start from that point. We start from somewhere else, and then we go into some kind of consultative process with communities. And we've got a range of methodologies for this, which work to varying degrees. But yeah, I'd be interested, I guess, to get Barnabas's perspective on that and how successful he thinks he has been, or him and his teams have been, in terms of engaging with communities.
All right. Thank you very much. That's the center of everything that we are doing as far as health is concerned. In Ghana, in particular, we have what we call the Community-Based Health Planning and Services, CHIPS. CHIPS is one of our flagships of healthcare to the people in terms of financial access, in terms of service coverage, and the rest. So the principles underpinning our CHIPS program is community involvement, community participation, and community ownership. These are the three key principles that underpin our chief's policy and program. And in fact, we've tried as much as possible right from the go to involve the community in decision making as far as their health is concerned. So at the communities decide, they plan, they agree on what the community needs are, they identify, and then together with partners, it's a multi-sectorial team. It is not limited to only health it involves opinion leaders, civil society organizations that form the committee. They all come together, they look at the resources, and then they mobilize.
Yes, I think this is
resources as this kind of approach, companies, individuals to need structures. Hello, because of this approach, the multi-sectorial approach and the concept of community ownership, involvement, and participation, we've been able to mobilize resources within the community for service delivery and public health education. And like I said, some of the community members, based on this approach, have donated some structures, some have constructed hospitals, some have constructed units of a hospital, some have constructed some, and some I agree very well that in terms of multi-sectorial, have donated center of everything that we do. So this is a classical. Thank you. Over.
okay. Thanks. I mean, I'm sorry, the last bit you were breaking up quite a lot, but I think we got most of that. So thank you very much indeed. We've got a couple of minutes left. Very, very quick. I mean, I got lots and lots of questions. I mean, what Paul Myers from Wales writes, and perhaps a very, very quick response to this. You know, our idea of a lot of the partnerships that THET arrange are between organisations in the UK and organisations in third world in LM and ICs, which involves people going over lots of air travel. Is this sort of process now? Are their days numbered? Is this type of relationship? Should it continue or not? Some quick thoughts on that.
Shall I take that? I think I can't actually see the comment right now, but I think, you know, this type of learning, I think that there's plenty of evidence now, and especially around THET's work, that speaks to the value in having that exchange at a professional level. I think what we learned during COVID is that so much of the sort of institutional capacity strengthening can also be delivered remotely. So much more now, we're actually, you know, we aim to travel less, be more engaged in the kind of virtual hybrid working world. And we've found that, you know, provided the internet holds up, you can do quite a lot with that actually.
Okay. Well, look, I need to wrap up now. There's less than a minute left. So I'm sorry, it's been far too brief a session. I think we could have carried on for a couple of hours. So just to thank my fellow speakers so much for some really carefully thought out and relevant ideas and thoughts as to the way forward on this, for all the people who've attended this session and for all the comments. And I'm really sorry that I haven't had a chance to answer everyone's question, but I hope we've covered a fair amount of ground. So enjoy the rest of the conference, and thank you very much, everyone. Goodbye.
Thank you.
So thank you for joining this session. This is clearly a rather more sobering topic. The ties between the UK and Myanmar are extraordinarily strong. And up until February 2021, they were increasingly positive. I had the pleasure of visiting Myanmar on a couple of occasions and celebrating the work of the Royal College of Paediatrics and Child Health, Imperial College, Royal College of Surgeons in Edinburgh, Imperial. There are so many wonderful UK partners who enjoyed close ties with Myanmar. Not to mention the almost 1,000 clinicians who work in the NHS who are Burmese by origin. And all of that positivity, of course, came to a grinding halt with the coup on February the 1st, 2021. And at these conferences, we've marked that moment quite often, including having the privilege of hosting Dr. Zawe So, who is the Minister of Health in the National Unity Government, which provides the alternative leadership to the military, who gave a keynote speech for us at our last conference. So February the 1st was the coup. And when the coup happened, of course, we as a health partnership community faced a choice. Do we lean in and maintain our connections with the country, or do we say this is too complicated and lean out? 10 days after the coup, we gathered for the first time. And as a health partnership community, we've been meeting regularly ever since, almost every fortnight with a few breaks. And I could not be more proud of what we are achieving collectively. Today, we have two of our most wonderful members of that broader health partnership community. Dr. Sansan, who is a paediatrician, and Marcus Wotton, who's a nurse working at the Royal College of Paediatrics and Child Health. I couldn't be more proud to work with them and of what they are achieving in these most challenging and awful times. I think I'll end there, if I may, allow you to introduce yourselves. And also, Marcus, I didn't read out some of the stats, so perhaps you can do some of that.
Got them all right here. So that's
fantastic. Fine. But thanks so much for joining us.
Great. Thanks very much indeed, Ben. I'm going to hand over to Sansan to start our session. And before you drop off completely, it's really important for us to acknowledge the incredible convening power of THET in the work that we are all doing together. And I think that's a very important element of what's occurring. Sansan, over to you. You've managed to share screens for a second time, proving it wasn't beginner's luck, which is great. Over to you, Sansan, for your point, please.
Thank you all the organizers and Ben for the introductions. I'm going to give this talk on behalf of all the long-suffering Burmese. I refer to my country as Burma, and don't get confused. And then this is a quote from the colonial times, famous poets and writers and journalists, and it's still true to this day. As Ben mentioned, we had a coup on the 1st of February 2021, and all the widespread all over the country has protest and call civil disobedience movement. It is a peaceful protest. However, the junta crashed down violently, arresting everybody and attack on especially healthcare workers and volunteers and schools, hospitals, clinics, villages, everything. So it's the unspeakable human rights abuses, refugee crisis, internally displaced people. And on top of that, we have environmental, ecological disaster, food insecurity, and Burma become a largest illicit drugs producing country. And it is the global and regional threat. And I'm going to give you an update on 4 major areas. One is education. Education is in crossfire. So this is the 2021 statistics, and then there's more attacks since then. This is a 1,800% rise in attack, and this is how the army attack from aerial bombardment and the heavy shooting that was recently at school. And nowadays, the children get education at the risk of their lives. The next area is the healthcare, as you all know. There's health delivery systems broken down. It's not only effect of the COVID pandemic, and junta use the viruses as a weapon and deliberately not controlling the viruses. And this is the healthcare workers protesting. And there are loads and loads of academic paper saying about how many doctors, nurses, healthcare workers, hospitals, clinics being attacked. But the news didn't leak out to their mainstream media. It's only in the academic papers. And in economy, we are getting poorer. We were not rich to start off with, and now it's even poorer. And the currency is so inflated. And half this value is the underestimate, though. This is a World Bank report end of last year. And Burma is naturally an agricultural country, so farmers can't go to the farming area and farm it, and their villages burned down, and they had become internally displaced people. They had to hide in the cave, and they are not productive anymore. And law and order, all the lawmakers, the elected member of the parliament, are either killed or imprisoned, or they are in exile. The people who need to make a law and order, like police department, become arms like mafia gang of the military. So this is what is happening at the moment, and not all is doom and gloom. We have some few limited escaped parliamentarian who formed the committee representing the people, and then formed the National Unity Government. This is their first year report written in Burmese. And like all Burmese, we are resisting more than 20 months. The CTM is still going on. And then thank you for giving me the opportunity to talk about Burma. Thank you. Over to you, Marcus.
Thank you so much, San. And it's very important that we recognise how much support you yourself and other Burmese diaspora in the UK are offering at this time. I don't know where we would be without you, and my comments that follow really build on what you've said. So yes, I'm Marcus Wootton. I'm a nurse and I'm a programme manager at the Royal College of Paediatrics and Child Health. And as Ben said, when the coup began, we found ourselves with a fork in the road. We either stop and say things are too difficult, and we abandoned our partners and our friends who we'd worked with for many, many years, or we decided instead to lean in. And I like that phrase that Ben used, lean in, and that's exactly what we did. I think we can be very pleased that we were the antithesis of fair weather friends. The work that we're doing, I can't talk about all of it because, as you'll understand, quite a lot of it is quite secretive, and that's okay, because that's part of the challenge that we currently face. And so we are supporting across Myanmar nurses and doctors to deliver care in a number of different ways, and that's through virtual supports, developing and building networks of virtual support right the way through Burma, right the way from the centre all the way through the ethnic health organisations. We're liaising with other organisations in other places, so the Royal College of Paediatrics and Child Health, and this, I have to say, is largely due to the convening power of THET, has been able to liaise and work with doctors, nurses and others from many different specialties and human rights organisations as well. And so this has been a true collaboration, both from the UK side to the Burmese side, but also within the UK as well. I certainly have never worked on such a collaborative program and such a collaborative effort. The numbers are pretty extraordinary. So we have delivered training to more than 3,500 health professionals. We have clinical procedure videos which have more than 30,000 views, a website which runs into many thousands of active users, mobile apps, many other elements of virtual support which continue to offer support on the ground where it is needed. That is not to say that these things are not without their challenge. We know that Myanmar is the most dangerous place in the world to be a health worker. And we know that internet security and internet coverage are still very poor, and we continue to advocate and work on those elements. What I would say is that thinking about the future, we continue to evolve and develop as the situation allows us. We have a better understanding this month of the situation than we did last month, and we'll have a better understanding of the situation next month than we do right now. And that's exactly as it should be. We should continue to evolve and develop our plans as the situation develops. What I think we have proved more than anything, and this goes beyond the numbers, is that community of practice, that collaborative approach, can work in contexts that are complicated and difficult. If we can do it in Myanmar, we can pretty much do it anywhere. And I hope that is something that the FCDO and donors continue to support us with, because we are incredibly grateful for their support and hope that will continue long into the future. That's probably enough from me, I think, certainly in the context of what I wanted to say. But I think we've got a couple of minutes left. We've got about 5 minutes left for questions in the chat. And I'm told that is something that's possible. So if there are questions in the chat, maybe that will be the next best place to go. Getting lots of heart emojis, which is very nice. I don't know if there are any scribbled questions going on. While you're writing your questions, some of you may be wondering how to get involved. We always need people to get involved. I always need people to write clinical guidelines and that kind of thing. Is there information about the work we're doing on the RCPCH website? A little bit, but I can't tell you very much about it. The best thing to do is to get in contact with either me or with THET, who can put you in touch with me. We don't make very much of this public for obvious reasons. We need to be very careful about how that works exactly. Security reasons mean that we have to be very very broad brush when we discuss what we're doing in a public forum. So I think, but by all means, do get in contact with us. You can find my email address easily enough. And I'm happy to go through it on a kind of one-to-one basis. Just to go back to the thing I was saying a second ago, in terms of protocols, we are continually looking to develop clinical guidance protocols, videos, and at the moment, clearly, a lot of what we've got is pediatrics and obstetrics, because we have good links there. So I think if you are interested in developing those kind of things, please get in contact, and I can certainly talk to you about how best that would work. What are the biggest gaps in the support that's needed, and where to go further with the work? So I think, yes, there is a bit of a summary there, Ben. Thanks for that. So the biggest gaps, San, what would you say to that? The biggest gaps and what further support's needed?
The gap is too big. So on the main risk is the security. So we have to be very, very careful. And then we are supporting the on-ground nurses and doctors. And that actually that we do what they want, what they needed is for in terms of like now they know that maternal and child health is very important. So we are trying to we are trying to get that maternal and child health. This is very important. Children are not getting any immunization. and so it is more of a burden for the parents, and if they don't, if they survive the infection, they get killed at school. So, and the other things that we are trying to set up is it's sort of like mobile clinic things, and we are training the on ground volunteers as well. The other things about this internet availability and security, it is a major issue for us, though. You might probably know some of the nurses, if they want to get internet access, they need to climb the highest tree in the nearest in their village, and just to get the internet access. But they are so motivated and more driven, so it is worth helping them out. So if you are so do you use visual to support the papers you produce art-based?
Do you want me to take that one? I think we could probably do quite a lot more than we're currently doing. And so, yes, again, if you'd like to get in contact with us, that would be incredibly useful. I've noticed there's another slide with another Q&A box with a whole load of questions that we haven't answered. So I've got a question about how effective do you think virtual contact is with Myanmar? Thanks for that question, Murray. I mean, it's clearly not as good as being there in person, and I'd much rather be there in person if we could. But I think given the situation that we're in, as I said, I think this is the very leading edge of what the 21st century has to offer in terms of virtual support. I think if you even look back 10 years ago to what people were able to do in Syria, we are way ahead of that. So I think we are doing the very, very best that we can possibly do in terms of virtual support. And I have to say, again, without wishing to talk too much about it, there are other things that we are doing that is not just virtual in terms of supporting supplies and that kind of thing. But again, it's very difficult without explaining too much more on that. Ben, you've unmuted. Do you want to come in there?
Yes. No, thank you so much, Marcus, and thank you, San. And it's a teaser. In some ways, it's unfair to give people so little insight into what's happening in Myanmar. But I think the message is clear. If you want to get involved, get in touch with us. We need the help. Marcus is completely right, I think, when he talks about how collaborative we have all been, and it's many institutions, it's many individuals joining together, avoiding duplication, seeing how we can support each other in order to support the health workers and the people in Myanmar at this awful time. I've just sent a tweet and it says, this coup will end, the partnerships and the relationships will endure. Amen. And that's what we're in the business of achieving. So thanks so much to you both, and those of you who came to hear this. We now have a break. We're back at 12 UK time for the final stages of the 2022 THET conference. So thank you for getting involved, and see you soon.
Thanks very much, everyone.
A very warm welcome back for the conclusion of the THET conference. We are first going to hear from Professor Dr. Marion Lynch. Then we're going to go into a roundtable panel discussion, which will reflect on all the conversations we've been having over the last 2 days, before we have final keynote contributions and closing remarks from our Chair of Trustees, Dr. Justin Ash. So thank you again for joining us. This first talk is from, as I say, Marion. Marion is a force of nature, of creativity, and of expertise, and it's a pleasure to know her and to have worked with her as well. But one of the things Marion excels in is speaking up, is raising her voice, is trying to use her influence as a highly regarded health professional to change the views of decision makers. She's ex-NHS, now working as a global health consultant, but she's very much associated with THET's HEAL campaign. She is a Gates Foundation goalkeeper, and in that capacity was at the UN General Assembly earlier this month. Marion, it's such a pleasure to know you and pleasure to have you here. And the stage is yours.
Thank you, Ben. And hello, everyone. As Ben has said, my name's Marion Lynch, and I'm honoured to be Honorary Advisor with THET. And I work with governments now to improve the quality of care. And I'm here to speak about health equality for all and help you act as advisors, as an advocate or an activist. But also, I'm a mother, a sister, a nurse and a nerd. And I add the nerd name because doing the right thing needs data. And as a researcher, obviously my phone's just gone off. As a researcher, I'm able to support evidence-based outrage. And I love that phrase. That phrase comes from women who in Africa who've been living with HIV, who were trying to change things. So I've harnessed their words, evidence-based outrage. And I add sister because you will see I need a band of sisters and brothers to join me to prove and improve equity and health. Next slide, please. So this evidence-based outrage centres around the 17 Sustainable Development Goals, and I'm here to help you share your power and your money. Now, you may know these Sustainable Development Goals. You'll be living with them. Your work must do something about them. And for me, the three that drive me are number 3, health and well-being, number 5, gender equality, and number 17, partnership working. And I could go through all the targets and the measures, but I'm not. Instead, I'm going to show you why it matters to me and why it could matter to you, and help you decide what you can do now, not next year when your life's sorted, not when the NHS is sorted, not when the governments have decided what they're doing, but now, because without action now, it will all drift and we can't have that happen. And I'm calling you, and I'm standing here now, or sitting here now, because I've spent my whole life working in health, mostly in the NHS. And my world was turned upside down when my sister suddenly got sick and she died. And we were like twins. We had our lives intertwined. My son called her the mother and me the other, because I was always at work and she was always the nurturer. And we lived five minutes apart. When she died, she left me a job, as little sisters do. And she said that I was to care as if she were there. And she said, please, Maz, do it like me, not like you. And that was a bit of a challenge because I was an NHS National Director. She was a foster mother and special needs teacher. So we had the career and the career in care. And something had to change. I had to choose to live life for two. And this changed not only my life, but the lives of many others as well, because I had to care as if she were there. Next slide, please. So this is where we merged missions of the Sustainable Development Goals and my role as advisor, advocate and activist. And that all came together in childcare in Kenya to care as if she were there. And here in front of you is Fee Day Care. See the little label at the top and the children that we work with. It's a small project. It's not national changes, but it's in the middle of Mathare informal settlement in Nairobi. It's as far away from the road as you could possibly get and provides food and care for 30 children 6 days a week. This means that their mums can go to work. And before our Fiona Foundation for Kids charity came here, the children used to be left alone. Many were malnourished and they all started school already far behind cognitively, so that they were never going to catch up. Next slide, please. Now, the mums are employed as carers and cooks, and there is training and there are grants so that mums not only have childcare so the children are safe and supported, but they also have better paid work. And this is all done in partnership with Tushindi. Tushindi leads it all. It's a local charity set up by a nurse who saw a need about 9 years ago now. So it has all the governance, all the monitoring of quality, the training, and all the other elements of well-run project needs. You have worked all around the world, I'm sure, and you know that this kind of governance structure is crucial when we're working in partnership. The nutrition is there, the training for mothers is there. Next slide, please. But remember I said I was a nurse and a nerd? Well, I wasn't going to put all my time and money into something that was nice, but didn't actually work. So I did my research and I continue to do so. And this research, which we need for credibility, is hands-on work and desktop data, because you need to be able to do both. So there's me measuring Immaculate, her name was. She should have been on a mat to measure, but we didn't have the mat. I had to measure her with our stand-up scales. She was also weigh her, and evidently her pants were really wet. So these measures are always quite difficult. And that's Margaret, the care worker who is funded to run Feed Acre. Next slide, please. So as a health person with skills, I was able to crunch the numbers, Z scores, interviews, observation work, a few PDSA cycles, stakeholder engagement, all these kind of things. And now, as a result of this intervention, over 1 year, I was able to measure that no child now is severely malnourished. That was kind of a bit of a measure, because you think everyone should be at a standard I wanted, but children were severely malnourished. Now they're just malnourished. And a few years later, we've changed the model of Feed Acre, that now it's small groups in mums' homes. COVID hit the way that we did things, but also any kind of project needs to change. Also, you see a picture of me there on the ground. Resources are crucial. So whilst I could work to the World Health Organization strategy, and I work with governance and government, so I can do things, I had 3 children and 1 spoon. And sometimes that reality hits when we can talk about resources, but sometimes it's the very basic resources of not enough spoons that actually make the difference for infection control or access to food. So I was able to be there and help train community workers. We've just trained new foster families in some of the safeguarding and trauma informed work. This is all as if Fee were there. Next slide, please. So why am I doing this? Well, I'm sharing my family story because I had a semi-secure NHS job with power and money, and I left it. And I love my job and my life in global health and research. I don't actually have a paid job at the moment, but there's something about the difference that you can make in the way you can make it that you need to grab. So I recently became a Gates Foundation goalkeeper, just as Ben said, which sounds great, but actually it doesn't give me any power or money, but it gives me access to it. And what I learned there was Melinda Gates was on the same page as me. Next slide, please. In the Gates report for 2022, she spoke of when she went to Kenya and met the people who were supporting informal daycare, and states that this is a triple dividend for people who are mums and parents and living in low income countries and with low income themselves. And she said, what if it was possible to do this everywhere? Next slide, please. Who knew we were on the same page? Mine is £1 a day. For these children, I think they've got more. But the evidence behind the Gates Foundation shows that investing in women and supporting childcare changes the economic elements as well. Next slide, please. So power needs to come to women, not just empowerment. Next slide, please. And this made me think of what I can ask you to do. Our politics is shocking. Our NHS is cutting millions. And we know the humanities, poetry and art, sustain us as humans because the science and medicine is not enough. So as I was listening to the Gates Foundation stuff, the words of Gangster Paradise were coming to me. Power and money, money and power, minute after minute, hour after hour. And this might come in as a earworm to you, but that money and power is what I want to call to you now. What about yours? Next slide, please. I'm leaving you with the questions, okay? What are you willing to do with your power and money, earned and unearned power, to get to us to the Sustainable Development Goals? Because we're not going to reach it without your research, your allyship, your education, You're stepping away from power you hold to make way for those not born with it. What evidence can you help to make and share? And in the other words of another amazing poet, Shakespeare pulled us and gave us ideas about what Henry VIII was trying to fight for. He called for a band of brothers. Obviously, I'm calling for a band of brothers and sisters now. So I'm asking you to go to the heal part of the THET website for the resources that will help you step up as an advocate, an activist, and an advisor. And I'm asking you right now, what will you do to care as if my sister were there? Thank you.
Marion, thanks so much. That was absolutely wonderful. And thank you for all the work you're doing. It's really appreciated. So I'm now going to switch gear and just let you know what we have for the rest of today. We have in a few moments' time the concluding roundtable panel, where we'll reflect on the last 2 mornings and the conversations that have taken place. We then have a rather special video, which is a conversation between Professor Sureljit Parry and Suzanne Edjang, talking generally about their time working together at THET and global health more generally. Before we then have our final concluding keynote contributions from Lord Crisp and Baroness Finlay, and closing remarks from Justin Ash. So we should be finished by 2 o'clock UK time. So that's 1 hour, 45 minutes from now. So this next session is really designed to help my colleagues who are writing the report of this conference. So I don't know whether you know, but every THET conference, we do produce a report. We do try and analyze what was discussed and reflect on it. And I'm delighted to be joined by a panel of people who I know well, and I think you all know well. Dr. Shams Syed, who is the Unit Head Quality of Care at the World Health Organization. Shams has been a champion of health partnerships, both as a thought leader and as part of the World Health Organization architecture. I will put a link to the Twinning Partnerships for Improvement website in a minute. I think I'm right in saying that Shams has been at every THET conference that we've ever run. He was also the first person I ever met when I joined as Chief Exec 7.5 years ago. So Shams, we are enormously in your debt for the influence you've had on us, and thank you for joining us today. We're also joined by Evelyn Brealey, who is Director of the Cambridge Global Health Partnerships. Evelyn has been at the Health Partnership Movement since, I had to look this up and then I had to check with her, 2008, when she joined Cambridge Global Health Partnerships. And Cambridge Global Health Partnerships is one of the most active partnerships with several health partnerships taking place. You might have seen colleagues of hers talking about Uganda earlier today, some of which are funded by THET, but many of which are not. We also have Dr. Hamdi Issa, who is Director of Community Health Services from the Ministry of Health and Development in Somaliland. And I first knew Hamdi because of her work at Imperial on frugal or reverse innovation with Matt Harris. And we'll be putting links to some of her publications in the chat box as well. And Hamdi now bears this considerable responsibility of working in the Ministry of Health in Somaliland. But she's worked very closely with THET and with King's Global Health Partnerships. And finally, my colleague from Zambia, Muleba Matafwali, who is the country director in Zambia. One of our newest member of staff, but also bringing an immense track record, strong track record in working in health. And in a country where we have some of our most active partnerships. So welcome to you all, which is my way of getting reassurance that everyone's here. I can definitely see Shams, I can see Evelyn, I can see Muleba. So I want to start with, if I may, with a general question about the conference, and I'll start with Shams, if I may, before going on to you, Evelyn, and you, Muleba. What for you were the standout moments of this conference, Shams, as opposed to some of the other conferences you've been at?
Yeah, thanks so much, Ben, and thank you so much for this opportunity to share some thoughts. Well, THET conferences are special, and I think we all know that, but that's for various reasons. The one thing that always stands out is the power of human interaction that is palpable within these types of conferences. And we know, and again, one of the things that's a hallmark of the THET conference is an ability to speak very openly and not to script. And that's really, really important for authentic communication. And that culture comes from years of experimentation. So that, for me, is the single biggest and important takeaway from the proceedings in the last couple of days, is that it's authentic and it speaks to issues that sometimes are not addressed in fora, and really important issues that focus in on power imbalances throughout the world related to global health. So those pieces I know are dear to many colleagues in this conference, but that is the biggest item that really stands out, Ben.
And do you, out of interest, do you feel that it works virtually in the same way that it used to work when we were all, with each other?
Well, we're all learning, aren't we? And we're learning how to communicate with the heart in the midst of a virtual call. Of course, the human interaction that comes from in-person communication. I hope that next year perhaps it can be in person, but the inclusivity of a virtual connectivity is something that we cannot ignore, and the landscape has changed forever. We really need to keep a virtual component to what we do.
Yeah. I mean, what we celebrate, I suppose, about the conferences nowadays versus the ones we used to have is just how many colleagues from low middle income countries are involved.
Exactly.
As well as that kind of eye to climate crisis and the carbon footprint that conferences generate. But I love those phrases. I'm very grateful to you for those phrases, the compliment that we're able to speak openly, and the years of experimentation. I rather like that. I do feel that's true, don't you, Evelyn? That we there's an element of us kind of embracing the new in the health partnership community. I hope that isn't the same as saying we're a bunch of amateurs who don't know what we're doing, because I think
No,
that's
it wasn't meant in that way, for sure. Absolutely not.
I don't think that's true, is it? It's like the way we've embraced technology. There's nothing amateur about that. We've learned to do it quite well. Evelyn, what for you has been the, if you like, the standout moments of this conference, please?
Yes, thank you, Ben. I mean, I absolutely echo a lot of all of what Shams has said, and I think part of that kind of, as Shams says, that authenticity, that ability to be open is some of the great combinations that you've put together in all the sessions of the workshops. Just thinking about the very first one, where you had Gaunima speaking after Richard Horton of The Lancet. Everybody knows The Lancet, don't they, really, in our community? And then there was that fantastic combination of the two who both brought as much to that session. And I think that's then continued throughout a lot. And then, yes, you're right, that because we can do it, because we're doing it virtually, we can do that. But yes, how do we then have a forum that also, yes, speaks from the heart, but actually we know that doing it face-to-face leads to depth, perhaps, that is sometimes difficult to achieve on the virtual. Yeah. I don't know, do we have to meet in the global north, we should be meeting in the global south, given that we know that there's such issues around visas. So were we to have a hybrid conference, why do we think that we hold it in London, for example, or in the UK? Let's hold it elsewhere. And I think there was what, I was sort of trying to think, gosh, I really, for me, what Marion just said about that outrage. I mean, I think we have to remain outraged. It was wonderful that the conference started, being positive and remaining hopeful. But I also think in having that diverse voice and in having a stronger voice as health partnerships, because we have absolutely, if I sort of think back to many years ago when I joined, and then the many THET conferences that I've been to along the way, and I think absolutely there's more diversity and we are stronger. But I think that outrage that we need to have, we feel passionate, we feel outraged because we live in an unequal world. There is continuing injustice, and how we pick that up from the conference and really use it to inform us as we continue when we go forward.
Yeah. And Marion's lovely phrase, evidence-based outrage.
Absolutely.
I thought that was great, because when we have those conversations about change, how change happens, it's both, isn't it? Yes, an evidence base, but it's also passion, it's persuasion, it's human beings buying into your worldview, and agreeing that change is important. So I thought Marion's evidence-based outrage was fantastic. As was Richard Horton and Galnima, as you say. I think it's just such a pleasure for me that we end up with these big thinkers alongside these people with the most incredible lived experience. The session earlier today, which Justin chaired, the opening plenary, and that focus on patient advocacy, voice and experience of patients. Shams, I know these are themes that absolutely dear to your heart when you talk about compassion and the kind of approaches we need to see in the delivery of healthcare. It's such a lovely privilege for me to be part of that combination of big ideas and lived experience. Muleba, this is your second THET conference. I made that up. Is it your second THET conference? Can you share some of your thoughts about standout moments for you? Can you hear me? I think, Muleba, you can't hear us, can you? No. There's a sort of sign saying, look, there you are. There I was enthusing about internet connectivity, doing things through the internet, and it all goes wrong. My fault. My next question is, Muleba, are you back?
Yes, I am.
Wonderful. Thank you for joining. What have been the highlight moments for you of this conference, please?
All right, thank you, Ben. So for me, this conference has been very enriching. I'm attending it for the first time. And so I think the standout moments for me in the conference have been, the common themes, the discussions that we've had around the common themes. So talking about solidarity, I think from the WHO director's message yesterday, how we need to work together, hold each other's hands, as we work towards even COVID vaccination programs. And also the common theme that was echoed by our Zambian Minister of Health when she was giving her speech, she spoke about being stronger together and how as a country, we have managed to record successes in the field of COVID vaccinations. When the program started a year ago, there was a lot of hesitation from the population, so many myths surrounding COVID vaccines, but really working together with partners locally and internationally, we've managed to record successes. As I'm speaking now, as a country, we have districts that have recorded 100% vaccinations. And as a country, together, we are approaching 60% overall. So really solidarity, not giving up on what we need to do, sending out the right messages so that everybody gets the right message and makes an informed decision. So for me, solidarity has really stood out for me. And also yesterday, when we listened to lived experiences as shared by the frontline workers who, put their lives on the line during COVID-19. We listened to presentations on the stigma that they've had to face, personal and professional. That stood out for me as well because as outsiders, we take so many things for granted. In our, I was reflecting in my country, Zambia. Many times we really point fingers at the healthcare workers, blaming them for things that are not going right. But really, we forget to take a step back and just reflect on the issues that they go through at a personal level, at a professional level, and even within our communities. So the lived experiences was just a standing moment for me. And also reflections on where we are coming from and where we are going as as a continent, as a country, and globally. We are just coming out of the COVID-19 pandemic, and just when we thought we are getting over that, there are conflicts happening around us, near us, far away from us. So it's really a reflection on how the past has been, the lessons that have been learned, and how we can forge forward, considering that there are conflicts around us, things are happening, our work is being affected by the conflicts that are going on around the world. So it's really a call for a new way of thinking and how to reposition ourselves. And yesterday there was a discussion also around community, just the reflection and always realizing that we are part of a community. Though we have physical borders, the work that we do really makes us just be part of this community that is working to save lives. So those are some of the key moments for me.
Thank you so much. By the way, thank you for your role in securing the participation of the Honourable Sylvia Masebo, because having the Minister talk at our conference was hugely appreciated, and that is one of the highlights, isn't it? It's also a very exciting time in Zambia, isn't it, with the new government. There's a kind of positivity in the air, I think, associated with this incoming government, which is very exciting.
Exactly.
Hamdi, I've said lots of nice things about you, and you won't know any of them because you were struggling to join the platform. But may I warmly welcome you and say that everyone else knows what I said. So it's a pleasure to have you. We're just reflecting on what some of the standout moments of the conference were for us, and before I then sort of dive into some of the details. Hamdi, can you answer that question, please?
Sure, Ben. Thank you, guys. I'm sure it was all nice things. For me, I think there's two major standout points. First of all, just this whole theme of reframing partnerships and thinking about this new era of voices. As you know, I've been studying health partnerships for a while, and when I first started studying health partnership, I was also thinking about how do we continuously reframe partnerships given the different types of shocks happening to the development architecture year in on year out. We need to be constantly thinking about how can we be doing things differently and better. So the fact that there was a whole conference based on this, and the panels and all the thought leaders working in and for partnerships got to think about the ways that they would sort of change their approach, change their processes, change their decision making, change their interactions with their partners to ensure that all these new voices are being listened to, and also taking part in this conversation of are we doing the best we can with the tools that we have, given that things are changing constantly. We can't be expecting that our partnerships to be staying the same. So for me, that was really important that you created that platform, allowing that. I think the second would be a talk that Andrew Leather was leading on, and it was about the SCALE program, this new idea that HHE is piloting on how we can look at health partnerships differently.
I think for a very long time we've been looking at the power play in partnerships, and are they fit for purpose? Are we creating sort of these power imbalances just by the way that we design partnerships? HEG from the beginning deciding that actually it's the secretariat lies at the low mid income country, which was Uganda in this case. Uganda gets to decide what they want. Uganda gets to decide, manage the money, manage the processes, and the UK healthcare professionals are only there to inject their technical expertise. I think it's sort of a real game changer when we're thinking about, well, what can we do differently to reframe partnerships so from the outset that there isn't that power imbalance. So I'm really excited actually to follow the scale journey, what we can learn, what went well, what isn't going so well, and how can we scale that up to other countries in the region, like in Somaliland right now where I am.
That's fantastic. Thank you. By the way, I watched that scale workshop as I commuted to the office today, which is one of the another joys of the conference being online, that people can access the sessions even if through recordings, even if they weren't able to attend them live. But that's a very powerful point. Shams, I feel I want to come back to you because those themes of patient activism, of compassion, the importance of community, of primary care, all of those areas where I feel I learn from you.
Ben, thank you so much. No, I've really enjoyed hearing the reflections from other colleagues, and for sure, the issues related to primary healthcare that were articulated by our DG is certainly something that we would need to really focus in on in the next phase of our work on institutional health partnerships. So one thing that resonates with everything that Evelyn, Malala, and Hamdi have highlighted is this importance of doing the partnership work at the same time as looking at wider issues of engagement, wider issues around inequalities. And that's where the primary healthcare approach really does come in, and really differentiating primary care from the primary healthcare approach, and the primary healthcare approach really focusing in on multi-sectoral action, empowerment of people and communities, and also primary care as we know it. So these are issues that I think the partnership community can consider, particularly when working in different models, for example, twinning arrangements between different hospitals, needs to consider that wider primary healthcare approach as those twinning partnerships implement very granular level quality improvement efforts on specific topic areas. So this, I suppose, really broadens the scope and understanding, because we all have an ability to nudge and influence directions of travel for health services and health systems. How can we nudge those health services and health systems to really consider people at the heart of those services and systems? And perhaps some of you had the opportunity to be a part of the session where my colleague Asia Odoglo-Kalev spoke, really trying to think through that holistic, systematic approach and relational human interactions. So those are a few things that perhaps the partnership community can really consider for the future. And of course, I would just emphasize the critical role of compassion within this effort. So I think that's also a very strong set of competencies and passion that the partnership community brings. But just reminding ourselves on compassion, really always being aware of the suffering that surrounds us and the suffering that surrounds colleagues across the world that are invisible, empathizing with that, but also taking the necessary action. So this outrage type of thinking can be implanted within a compassionate approach to health services and systems. Ben.
Thank you so much. You share Hamdi's excitement about the scale program and that kind of shifting of power relationships within it?
Absolutely, yes.
And Evelyn, you've been involved in that program, of course, and Tom Bashford spoke as part of that panel. Is that your takeaway as well from the SCALE program?
Yes, it is, and it's interesting in a way because it came out during the session almost. I don't know that we had really understood it as that significant shift, which absolutely is key, isn't it? It's so important. Yeah, and we're very fortunate to be part of that program, and to see where that learning takes us. And it's fantastic as well that already, I mean, it's very new, but already there is such interest also from sort of others within East Africa. But then, like Hamdi was saying, I mean, Somaliland is East Africa, I think, up a bit, beyond. I mean, yes, there's much that we can learn from a slightly different way, and that reframing, isn't it? It's a slight reframing of health partnerships. I mean, what Shams, I really enjoyed listening to Asiya yesterday, and I thought it was quite interesting because how Richard Horton had started off by saying health is a quality that's created in community, and then she so nicely picked up on that because she then went on to talk about what a community is, and a community is no longer a geographical location, or it can be a geographical location, and then so much more. And that's what we are, aren't we? In this conference, this extraordinary community that I feel so fortunate to be part of, and that gives me that, with that outrage and that passion, gives that strength, and it gives us all that strength, and how we work and across this, and then yes, absolutely, the only ever increasing diversity, which we know is so important. And again, like Tikala said this morning, it's within that diversity that we forge partnerships. So all, I think these are all the really important themes that have kind of been brought to the fore in the conference. So I suppose the challenge for us all is now kind of taking those forwards and really putting them into what we do day by day, because that's really, isn't it? It's the implementation that will start to make the changes and make the difference.
I think that for me, like you, that sense of community building, of movement building, as Lord Chris sometimes calls it, is terribly important to me. And I suppose what we were trying to do in this conference was to embrace the conflict, to embrace the dissent, if you like, or what Mosen Malik calls the contestation, which is the quote I used in the blurb and talked about at the beginning of the conference, to embrace that because it comes from very legitimate places, experiences of racism, experience of gender inequality, experience of inequality and access to vaccines, with examples I was talking about at the beginning of the conference. But our response mustn't be to, for me, endless contestation, as he says, but endless collaboration. And I was so thrilled when Richard Horton sort of endorsed that. But I'm wondering, Hamdi, Muleba, do you think we've achieved that in this conference? Have we done justice to the anger that legitimately is out there? And have we succeeded in being as diverse as we hoped we could be? You're on mute, Muleba.
Sorry about that. Yes, Ben, I think to a large extent we have managed to really go beyond the borders in this conference and unpack the issues that we all face in our respective countries, in our respective offices, the topics that we need to be discussing, the inequalities. Listening to the presentation from Malawi this morning, I was really able to relate. And because, Malawi and Zambia at one point we were one. So clearly the issues they face are the issues that we face. And I was critically just listening and thinking through how we can ensure that the people we work with in the communities are brought to the table and understand the issues that we are trying to raise. So what was highlighted in the morning presentation is the issues of working with communities and making them and it's not a Western world agenda, but it is really our agenda, even as Africans. But reflecting through that statement and reflecting through, how the community reacts when you bring that conversation to the table, to a meeting, it's really because for a long time, what we have seen are Western world champions, talking about race, talking about inequalities within our own circles, within our own settings, within our own homes, within our communities. These are issues that we see, but we don't have a voice. For a long time, we really don't have a voice. So as we get more exposure, as we attend even conferences such as this one, as locals, as professionals working in these settings, trying to make everybody just appreciate what we're trying to do, we'll start slowly seeing changes. And just going back to that example from Malawi, we need to raise more local champions. They need to see those of us who are able to speak the language and break it down for them. Those of us who are able to relate to the community leaders, our chiefs, our headmen, and make them understand what we're trying to do, even around COVID vaccinations. Why we are urging everybody to take the COVID vaccinations, why we are urging everybody to freely and openly talk about race, freely and openly talk about gender inequalities. Even in that, the example that was given in the morning around having a community meeting and then a man stands up to say why, if it comes from a point of love and really, the work that we do in NGOs, as somebody I worked with previously put it, it's a labor of love that we do. And when we approach the work, we approach the community, we approach the people that we are talking to at all levels from a place of love, they will be able to see that we mean well, and they will be able to, relate and be able to sit and listen to us. So I think what this conference has managed to do is to bring those stories, the lived experiences, the shared experiences direct from the field to the core. And I think we'll leave this conference with a different mindset in terms of how we approach our work. Thank you.
Thank you so much, Malaba. Hamdi, are you convinced?
First of all, then I think any forum that actively brings together all the partners on the same platform is actively trying to at least do something around that issue around collaboration. Are we doing it right? There are times, not necessarily the THET conferences, but in other conferences where necessarily one partner was speaking for the other and they were never present to share their presentations, share their voices, share their experiences. So first of all, bringing people to that table, I think, is hugely important. Have we done collaboration right in every partnership at every stage? No, but what we are doing is that we're constantly learning and we're asking each other, what are we doing? What could we be doing differently? Are we thinking about these issues around gender mainstreaming? Are we thinking about the issues around power? Can we be continuously learning and changing our approaches? And in some of the panels, I felt like that we created this sort of this forum, this space where people could have honest conversations. The panelists, lead panelists themselves could play devil advocate, where they could just provoke some thoughts. And I thought that was really important in allowing us to be comfortable enough to have those honest conversations, allowing everyone to speak up and not silencing anyone's voice. Even just bring them to the panel is only sort of the half the battle, but making sure that everyone has their chance to share their lived experiences. And I think for a very long time, when we've been talking about, for example, gender mainstreaming in partnerships, I think a lot of the times we just used to think about gender sensitivity. Look, are we thinking about gender? And I don't think that's nearly enough. We need to be thinking about gender transformative approaches and what are the steps that we're actually taking
practical steps that we're actually taking to look at the root causes of gender inequality that are taking place in the ways that we develop our programs, in the ways that we implement our interventions. And in these partnerships, I'm starting to see that people are actually trying to tackle some of the root causes. And I think that's like, I don't think it's ever going to just reach perfect, but I think as long as we continued and committed to really listening to each other, listening to the partner, and having the space for honest and raw conversations, then we're edging towards that space of where really these partnerships still can be this vehicle for a true sense of collaboration.
Yes, my goodness, that phrase "Western world champions" is really sticking in the brain at the moment. Well, thank you for that, Hamdi. I suppose that's what we hope, isn't it? That we can provide those forums where people can engage in open and honest ways. And the longer we know each other, the more familiar we are in some ways, the better we can do it. But it is that reaching for systemic change, not just the kind of immediate intervention. It's changing the system, not just the institution, or upskilling the decision making, not just the individual. Those are the kind of challenges that we need to rise to, isn't it? Shams, I'm acutely conscious, so forgive me for putting it like this. I was trying to think how I can do it. I'm acutely conscious that basically you've been promoted and you've got a wonderful new role. You have been such a thought leader, as I said at the beginning, in the health partnership space. I just wanted to sort of ask you to step back and give perhaps a bit of a wider reflection on your time in the current role and how you'll be using that in your new role, but some final sort of advice for us, reflecting on all the years that you've been so frankly inspirational and supportive to the health partnership community.
Yeah, thanks, Ben. Never like to think of it as advice, but this more sort of a reflection. One of the most powerful parts of the partnership movement is a recognition that small can be beautiful. And the global health arena finds it very hard to signal detect brilliance from small institutional health partnerships. And again, we can just be open because the culture of this conference is open. We have a responsibility to somehow amplify what we are able to achieve in the smallest institutional health partnerships. Sometimes includes a handful of people that are continuously and passionately moving forward a particular area of work. And that's tough. So one of the things that I think organizations like that can do is ensure that the voices of the smaller partnerships are placed within the partnership arena, which includes, of course, really large institutional health partnerships and those that have quite a lot of resource behind them. That's one thing that I might highlight for the future. And the second, and I'll be repeating myself somewhat, but not to underestimate the power of compassion within institutional health partnerships. That's a driving force and a glue for many institutional health partnerships. And perhaps we can continue to elevate the concept as well as the practical application of compassion within institutional health partnerships. And maybe the third point, really focusing in on what all of my panel colleagues have mentioned, is that relentless focus on learning and actually not being always politically correct related to that learning. I think we can all be sort of paralyzed by not wanting to say the wrong thing. And that can also be applicable related to issues on race, gender, and that mutual accountability, because we don't want things to, the pendulum to swing in such a way that we can never critique the southern partner. We need to be able to critique all arms of a partnership when that mutual accountability is not being held up. So that might be a little bit controversial, but again, in the safety of this conference, I think we should be able to hold ourselves mutually accountable and learn from that. And that would be the point of emphasis, Ben.
Yes, and in some ways, the next video, which is a conversation between Eldred and Susanna, is a conversation across generations, across different lived experiences. And I think I can agree with you. And that was one of the thoughts that we had putting together this conference, which was feeling comfortable with awkwardness, and if accompanied, as you've just said, by humility and an ability to listen, then asking for help about how to navigate. And someone was saying that went there in the opening plenary about it all starts with conversation and listening to lived experience. Evelyn, can I ask you a similar kind of bigger question? So I've just outed you as being involved in the health partnership community since 2008. Goodness gracious me, when presumably you were a volunteer teenager.
Nice try.
Stepping back and looking over that time, how do you think the health partnership approach has evolved?
I think we've absolutely found our voice, and we've become much more confident in that. I guess, kind of picking up slightly from what Shams just said in terms of sometimes not being politically correct. I sometimes feel a little bit uncomfortable that there is the potential that health partnerships could be and are sometimes used in the UK as a giving back, such that it's okay for us to continue with the overseas recruitment. And I know it's massively complicated and there's all sorts of factors. But that conversation at the very beginning, when it was the countries from which we're recruiting who bear the responsibility to put in place the incentives to bring people home again, I thought, I'm not sure about that at all. And so I think as health partnerships, we absolutely have to use that stronger voice we have. And we perhaps we need to come together effectively on some of these key issues and be clear about where we can take a stand collectively, because collectively there is the evidence, crucially, that can help us stand on some of those, and perhaps to just be a little bit careful. We talked about global disorder. I mean, there is global disorder, and in that, it's really important, isn't it, to stand firm on some key principles, and where we know. Sorry.
Yes, do not lose sight of the ethics. Or
yes, absolutely.
Yeah. And Andy, I'm just so excited. I'd love to sort of sit down and have a long coffee with you. I'm so excited. You're moving between Somaliland and the UK now. You've got this amazing new role in Somaliland, which is very much on the front line from the ministry. And how do you now think of health partnerships in the context of your new role? How do you are you still as enthusiastic about them as you used to be? Can you still see that they add value? Or talk to me a bit about that, Winnie.
Ben, that's a really interesting question, because obviously when I was in the UK studying partnerships and never being in a partnership, never delivered a partnership, I was looking at it maybe from an academic point of view and thinking, just why can't we get this right? It makes sense. Why can't we just create an equilibrium in these partnerships? And then I moved to Somaliland, and as you said, I was working for the Ministry of Health and overseeing some partnerships, and then really seeing on the ground the challenges being faced with the balance between trying to get the work done whilst also ensuring that we're keeping the balance between knowledge, between power, respect, all of that, but whilst also all these tight deadlines. And I saw that there's this. Sometimes it's so easy to forget about some of the key elements to a partnership when you're just trying to get the work done. And then, of course, I actually engaged in a partnership, the UK Somaliland Partnership for Quality Care in Somaliland, that was supported by King's College London and actually WHA colleagues, Shams, from your quality care team. And just seeing it then and seeing sort of the wonderful work that you can do when you bring together people who are really committed to ensuring every voice is heard, something that we did in that partnership, and I commend colleagues from the UK, colleagues from WHO Geneva, was actually everybody's voice mattered, everybody was listening. And we were also trying to also include the beneficiaries, so not just the people that were on the high income country, low income country side, that were sort of the quote unquote technical experts, but the beneficiaries and them feeding in. And I think it's really important. It comes back to how can we constantly asking ourselves, are we doing the best we can with the partnership model, or do we need to keep reframing it? And I think there's nothing wrong with constantly having to reframe it. I think the issue is when we become stagnant and we think that we found the model. That's the biggest challenge. So for me, it's really important about something that Richard Hodson said, the parity of esteem, but he was talking about interprofessionalism. But then I started thinking about the importance of parity in knowledge, the parity in power, the parity in learning, the parity in decision making. If we focus on that and trying to search for that whilst we're doing these interventions, whilst we're doing this great work, I think we will really create this sort of space where partnerships can be this more powerful than they are now.
Yes, thank you so much. And Maliba, you've got such wonderful experience with, Family Health International, PATH, working for various NGOs. As you say, this is your first health partnership conference. Stepping back, what's your sort of impressions of the strength of the health partnership community versus those other experiences you have?
All right, thank you, Ben. I think the health partnership work and its importance cannot really be, overstated. It's really been helpful, even in the Zambian setting, across all sectors, not only THET, but across the HIV and AIDS sector, malaria, TB. It's really forging these partnerships that are able to come to the table together, plan together, and then see how best we can serve our communities. And so really reflecting back, even when I was with PATH under the Bill and Melinda Gates funded Malaria and Elimination Partnership Project, the project itself was really centered around health partnerships. With experts in America being willing to come to the table, work with us in Zambia, and see what we can do together. I found those years very fulfilling because, we were at the table planning with Ministry of Health, sitting with provincial and district medical officers to really look at the problem and come up with local-led solutions. So among the programs that we had implemented, community-driven programs around mass drug administration, the distribution of mosquito nets. It was about partners coming together to see how best we can tackle malaria in Africa, in Zambia in particular. The successes of that work speak for itself even today. As a country, we have a few communities that have been malaria-free for a few months, and it's just really the power of partnerships. And one thing I've learned from THET in the 6 months I've been here is the interactions I've had with some of the partnerships, that are in Zambia, the commitment that I see. One partnership that really strikes me is the partnership that we have with Birmingham University and the University Teaching Hospital, helping to train nurses in critical care nursing. When I read the history of that partnership, when I see the work that is being done firsthand, it really speaks to compassion, I think, which Dr. Shams spoke about. So we have two people, Joy and Chris, most of you are familiar with them, who've been in Zambia for a long time. when I sit with them in a meeting, listening to Chris share the work that he's been able to do in Zambia in the 5 years that he's been here, it's really amazing. I've been in the public health sector for years, and I thought I knew it all. But listening to Chris, who knows Zambia more than myself, is really a work of compassion that I see. And even the work.
Thank you so much.
Hello?
Thank you so much. And I think when you talk of Chris and Joy, of course, you remember, well, you remind me of how passionate people are involved in this community. And I think that's partly why we say it's all about relationships. But thank you all very much. I kind of want to carry on, but we're not allowed to carry on, so I'm going to have to stop. I asked you to help do a task, which was to kind of help us shape the report that will emerge from this conference. And I think you've done it brilliantly. I think, the nuggets, Shams, your wonderful kind of point about, a QI initiative here within a certain partnership can have a bigger impact, a sort of wider value than just the particular project or initiative or indeed the partnership. I like that very much. And that thing about people listening and learning from each other and contributing to the evidence base, being involved in research. It's an exciting group of people, isn't it? Thoughtful people who get involved in health partnerships, I think. We will never be 100% successful, so the journey continues, conversation continues. And I'm going to turn now actually to a video recording, which is a conversation, as I said, between Professor Sir Eldred Parry and Suzanne Edjang. And in some ways, I'm going to be open and honest about this. Some ways we hesitated. We have enormous regard for Eldred, but he's 92 years old now, and he's in a different place to where he once was. I'm very grateful to Susanna for having this conversation with him. We're squeezing, if you like, every moment we can get in Eldred's company. And he enjoys the company. He makes us welcome in his house despite the challenges that he faces. He was with us in the House of Lords on Wednesday night, reveling in colleagues like Evelyn and the success of the health partnership community. But these are tough times. So I show this video in the spirit of Shams, that point we were making earlier. This is a conversation across generation, across different lived experience. So as I hand over to the video, thank you very much to you, the panelists, for contributing to that last session.
Okay, Eldred, yeah, we did this a
Well,
bit yesterday.
Susanna, it's lovely to see you again. We want to see more of you in London in the future.
Yes, but
because you've had a star-studded past, and I have no doubt it'll be not exactly a star-spangled banner for the next phase. I hope not, anyhow.
well, Eldred, this is amazing coming from you. Amazing words, but you are always an amazing flatterer. Yes.
You know what the scripture says: "A flattering tongue worketh ruin."
Yes, but anyway, it's very nice to hear those words from you.
Thank you.
I admire you, and I love to be with you.
I was seconded to Ibadan, Nigeria, for a year, and the research was going well. So I asked if I could extend to 2 years.
Mm-hmm.
And one of my very distinguished colleagues at the Hammersmith later said, "Are you a something fool?"
Yes. Mm-hmm.
And I said, "No, I'm loving it."
Yes.
Well, as a result, the following year, I was invited to go to Ethiopia to the new medical school in Addis. It was a wonderful initiation to the beginning of things.
Yes.
And we realized then that the whole pattern of global health was cockeyed. Because the pattern was, we know what you want,
Yes.
and that's wrong. We said we should be responsive, not prescriptive. And so we responded to needs, and we're not prescriptive.
How I started in global health, you know, I was a forced migrant into Europe, and then I was trained as a physiotherapist in Spain, came to the UK working community health, and was able to study development economics, and I was lucky enough to, when I applied for jobs in international development, I saw a job like at THET that tick all the boxes of what I wanted to do. No, I was about the principles of THET, of being responsive, not prescriptive, not having offices in countries, and it was about systems, and it was in the context of the Millennium Development Goals. Yeah? It was very interesting for me. It was very interesting and enjoyable to fill in the application form and to go through the interview process, long interview process. And
The whole day, wasn't it?
it was like 2 days or 3 days of interview, you know, the interview, the presentation, the discussion with the other candidates. All you made it very hard to go through that hurdle. But it was also interesting to me. The team, it was small. It was women-led at the time. Very few organizations were women-led. Sarah Adams was running the team. And so it was an amazing opportunity, and it was an organization that was flexible and willing to explore and do different things. That was really interesting to me. Yes. So I don't know. I was very glad, and it allowed me to grow as a development practitioner, and also for the people that we saw coming in and out of the office. No, it was one of the few organizations I saw, particularly because we work with the health sector, people of all races and genders and in senior positions, from female surgeons to people like Sylvia Watkins or Jimmy Cocker or Biku Ghosh, you know, around. So that was also very good for me, because those were things you didn't see in the development sector, and still you don't see in the development sector much.
That's roughly the pattern of the beginning. And then when we Harry Overseas project account was backed by the professor of history at Hull, who became at Leeds, who became the vice chancellor of Hull, and he backed us.
Yes.
And he was a trustee of the Lennox Boyd Trust, and so it rolled on from there. We got money, and then my great friend Richard Southwell, a very distinguished Silk, bankrolled us for the first couple of years, and we started I started going back to the medical schools I'd been to and asking them what they needed. And they said, train our young men. Now, the fashion at the time was grassroots. And the head of the Jimmer Medical School, which was set up by the ministry, because the Addis Medical School was irrelevant to the community completely, and had been appointed by the ministry during the dark days of the Derg, and it was a community-based medical school which sung to the same hymn sheet as I did. And so it just went on from there. And I went back to Ibadan and to Addis and to Ghana. And we rolled on and rolled on. So, I mean, I think that how have you evolved since then as a result of working in THET?
Well, I think the evolution it is that it was very interesting from working at THET. I went to work and with institutional partnerships. I went to work with Nigel in creating, bilateral partnerships between two nations, the UK and Zambia, and other work that Nigel was doing. I think one of the things that THET did is sold me into the idea of the power of partnerships. Yes, on listening to others, yes, rather than prescribing. And that is, those principles I have carried with me in the design and implementation of bilateral partnerships, national partnerships, and global partnerships during my time at the UN as well. And while doing other work, so I believe, it gave me the tools, and also because part of my job was going around all the UK, and working with these amazing people, from Brenda Longstaff to the Abergavenny
And you mentioned to me earlier there was a brigadier, chairman of a health board in the North of England.
Yes, the Trust, Brigadier General Ramsey, and the work in Zimbabwe and Malawi.
Yes, he became a very good friend. Great memories of Somaliland.
Yes.
We went to Boroma University.
Yes, Boroma, yes.
Effectively started the medical school.
Yes.
And they put me in a hotel in Boroma.
Yes.
And I went out for a walk in the evening.
Yes.
And a man came up to me and said, "Are you crazy?" And I said, "No, why?" He said, "This is Somaliland, don't you know?"
But what about all the changes, like the transition, like the different chief executive that has had, the team, like how last time I was in the office, so big,
Well,
I saw a big office compared to the one. Yes.
Ben had the idea of moving laterally and broadening us, and having a communications officer, which we never thought of.
Yeah.
I think now we've hit a bullseye with Justin Ash, the new chief executive. The new chairman, I'm sorry.
And we also did a lot of work with diaspora groups at the time, yes. But I believe that we didn't institutionalize that work, and eventually fell through. In a way, we did a lot of work with diaspora groups because they were also instrumental in ensuring that that the links were even more effective, and sometimes even that they were formed. It was responding to some of those requests and engaging members of the diaspora, but also with the royal colleges, professional associations. And then there were also the specialist links, like the eye people, Vision 2020, Nick Asbury and Marcia Sonderman, and the library links. Those were also really interesting developments.
When we started that, I went around the medical schools, and they were bereft of books.
Yes.
And there were potholes in the main street of Kampala.
Yes.
And it was a bombed out city, and effectively then in those days. So the whole scenery has changed overseas, and now it's become fashionable almost to do things. But it wasn't fashion; it was concern and genuine involvement.
Yes.
I mean, I remember I was discussing once in Ethiopia, when I was staying in a hotel, the usual one I stayed in. And I was sitting at dinner with some person, English person, and not Scottish or Welsh or he was very London based, and his whole attitude was wrong. He said, "I heard that there were grants going for nomadic people, so I thought we'd come here and try to get a grant." So they could take their, whatever it was, 10% for running charges. Well, that to me was absolutely the wrong way around. But there we are.
Well,
That was the pattern at the time.
But it's changing now, no? There is also, which is interesting, in reflecting also the health workforce in the UK, there is more participation in international development from people from the health workforce from different backgrounds, and also the growth of organizations trying to do something and contribute. Some of them also collaborate with links or health partnerships, as they are called now. But it is, but it still is. I don't know. It's still, I find that the space for those groups is not necessarily there.
People now talk about salaries. They never talked about that in our younger days.
But they need to talk about salaries now.
They need to.
The cost of living is
There we
tremendous.
are. That gets worse the more
for
and more.
nurses, yeah.
Yes, the cost of living, but it's awful to think of it all being motivated by money.
Well, I think most of the nurses I have met through partnerships or otherwise and in developing countries, they are committed, no, to their work. You know, you couldn't do that work if you didn't have some sense of vocation or sense of duty. Health professions are global professions, no, and people move, no, and this migration is very difficult to curtail, and but also it can be circular. It can become circular, and how do we ensure that at the very least basic health needs are covered everywhere in developing countries and developed countries, because we are seeing inequality in access to healthcare in both rich and poorer countries. No, we are seeing, particularly with COVID, we saw similar problems in rich and poor countries in terms of trust to the health systems, in terms of limitations in the delivery, particularly to the poorest, and access to care. No? And the other thing that I believe that was interesting with health partnerships that I think is critical for the conversation on global health is there was a lot of innovation in delivery of healthcare, and also in how health professions are designed in developing countries that we were able to tap in through the health links or health partnerships, and also about other types of innovations and ways to democratize healthcare that have taken place in, from South Africa to India to Bangladesh to even Ethiopia, with the health extension workers, and how in other richer countries have been trying to learn about it. I think that was really
the point
really
you
good.
made there was that global surgery was neglected completely.
Yes.
But we had a colleague in Abergavenny.
Yes.
And he was a surgeon.
Biku Ghosh?
Biku Ghosh, yes.
Yes.
You see, Biku Ghosh was not a normal, he wasn't born in Britain.
Yeah.
And he came to this country and he's contributed a lot. And he was the one working to train assistant surgical officers. And they were the lifeblood of of surgery in East Africa, but not in West or not in Ethiopia.
Biku and
And so
Dr.
he
Aberra, yes.
trained
in
health
Ethiopia.
officers
Yes,
to do emergency surgery.
yes, yes.
So
But
it was a very exciting time.
it was exciting, but it was also something that also it was about creating those true partnerships. No?
So
You
I
know?
now do, I enjoy, as I shall enjoy when we get premises,
Yes.
meeting young people who've got ideas, who are motivated now by wanting to change the world. And wonderful, let's catalyze that.
Yes. The lesson here is also one of the wider issue of dependency, no? Dependency of developing countries on aid, dependency of aid organizations on budget support or support from government agencies. And now, it is about how we can change that model for the delivery of support to our partners when they require it, yes? When they require it. And I think here in the UK or in other countries involved in global health and supporting global health, we need to think about how the model can be different so that we don't let our partners stuck. Yes, stuck.
I'm going to follow your next senior post with delight.
We will see what happens.
We'll see. I don't doubt they'll have the wit to appoint you somewhere.
We'll see. What do you tell us about your memoirs, Edwin?
My memoirs?
Yeah, what happens with them?
I'm full-time overall responsibility for my beloved wife.
Yes.
And we've been married now over 62 years.
Helen, the wonderful
and
Helen.
We've been 60 years in this house.
Yes.
Next year.
Mm-hmm.
So this is our roots, and therefore my time is less than my own than it would have been if I was full-time writing.
Yes.
But I've written the first 15 chapters.
Ooh, yeah.
And now I'm on to the last 3, and one is going to be a book, and that the idea about the book and the return to Britain and the effect that had, and the last one is going to be Then and Now.
Okay.
Then and Now shattered me. When we drove into Nigeria from Benin in the 1970s, we drove through deep rainforest. When I took the same road 3 years ago, yes, 3 years ago, just before Helen had her hemorrhage, it was all cut down.
Okay.
And I see the future in many ways as governed by the 2 great pressures, climate change, and we're hearing about the starvation in the Horn, and overpopulation.
So Susanna and Eldred, 2 very old friends, a great deal of affection clearly between them. I hope you sort of approve of our sharing that. As I said at the beginning, we think very highly of Eldred, and inviting him to have a presence at this conference felt appropriate. I now turn to the final conversations of the conference. conference. And I'm very, very pleased and honoured to introduce Lord Crisp. Many of you will know him, perhaps everyone knows him. I wouldn't be surprised. Lord Crisp is patron of THET, which we're very proud of, has been the architect of so much of the thinking around health partnerships, both in his own writings and through his co-chairing of the APPG on global health. And it is, in fact, the APPG on global health that he's going to focus on in this particular talk, reflecting on, I think it's 10 years, Nigel, isn't it, since you established it. We're very grateful to you. After Nigel's finished, I'll introduce Baroness Finlay, but for the moment, over to you, Nigel.
Thank you very much indeed, Ben, and what a privilege to join you, and what a privilege to come after that fascinating conversation between two such impressive people. Great pleasure to join you, great pleasure to have a chance to talk a bit about the All-Party Parliamentary Group. As what you haven't said is that, just as I'm delighted that Baroness Elora Finlay is going to take over the co-chair and the parliamentary leadership of this group, THET is taking over the background running of it, and I think that will both be good for THET, but it'll also be good for the All-Party Parliamentary Group to be well rooted in the fascinating work that you do more broadly. So I will be fascinated to hear and see how the All-Party Group continues in the future. My task now is just to actually talk a bit about it and what it's done in the past. And I'm going to try and share my screen. Let's see if I'm able to work out how best to do that. I think I've probably managed, actually. I hope I have. And I start from the beginning. There we go. I think I'm showing my screen. I'm sure, Ben, you'll tell me if I haven't. So I'm going to give some reflections on turning the world upside down, the All-Party Parliamentary Group on global health, and a little bit on THET as well.
It has worked now. That's very odd. Maybe colleagues are helping. Sorry to interrupt.
Right. Okay, it's on the screen now, is it?
Yes, thank you.
Yeah, great. So I'll say a bit of reflection on the group and some other things I'm interested in, including on THET. But let me just start off with a little bit of the history. It's actually been going 11 years. We set up in 2011, and its role, because it's an all-party parliamentary group, so it's in Parliament, as it were. Its purpose is to influence government and Parliament on global health issues, and we address a wide, cross-cutting range of issues around global health, cooperating with other APPGs and avoiding duplication. So we don't do the same stuff as the APPG on the UN goals, for example, or indeed Action for Global Health and others. We try and avoid those topics, but talk about some of the underlying issues. We produce major reports on significant issues, and we hold meetings on global health issues and convene people, bring people together. And I'll just give you a few examples. So actually start with the people. We've been going 11 years, as I say. In that period, we'd had 3 MPs as chairs. MPs are always chairs of these groups. Alan Michael, Meg Hillier, both from the Labour Party, and then Dan Poulter from the Conservative Party, myself as co-chair throughout this period. We've also had an absolutely brilliant group of policy directors and coordinators. Susanna, actually, I put you on the list because actually you helped me set it up, even though I don't think you were ever technically part of it. As you said earlier, we worked together in Zambia, but we decided to run this group together and set it up. And people will see that there's a link there to THET, of course, and some may know that John T. Rowland is one of THET's managing trustees as well. So there's some good links there, but a fantastic group of young people who've worked with us for a year or two over these last 11 years, picking up some very important issues. We have also, just for sort of completeness, had a range of sponsors over this period, about 7 or 8 at any given time. If you look down that list on the left there, you'll see that these are all non-commercial. We've avoided commercial enterprises, with the one exception that you may notice there, which is the Lancet, which of course is a commercial organization. But we've gone for the people who are actually the thought leaders in global health, really. And on the right-hand side, you can just see a little range of the MPs and peers who've been officers of the group, not just members, but actually officers of the group as well. And as you can see, there's really quite a wide range there, and some names that people will be familiar with. But let me go on to what we've been doing. And actually, in those 11 years, we've produced 10 reports, and some of these have been quite significant. I'm going to talk about 2 or 3 of them later on, but just they run from left to right, top to bottom in terms of orders. The first one, All the Talents, very much about task sharing and producing interesting examples where it's been successful task sharing, and others where it hasn't been. Second report was one of the more influential ones. It advocated very heavily the continuation of and the development of the grant that came to THET to support local work. And we've been a great advocate of the government providing partnership support in that way. Sorry, it's not happening now, but maybe there's going to be another chance to come along for that in the next few years. Next one was around patients, and the next one about mental health. One of the big themes for us has continued to be mental health and the importance that we talk about mental, physical, and social and environmental health together. The health of the individual is intimately linked with the community, the society, and the economy, and the planet, as well as across in broad terms. The next one at the top there was about mapping out. This is a report done for us by the London School of Hygiene and Tropical Medicine, about 200 pages long. They worked out in great detail the UK's footprint on health globally, what we're doing commercially, what we're doing through government, what we're doing through voluntary organisations, what's happening through academia, and demonstrated the extraordinary reach of the UK in health globally at that particular date. Coming down to the next row, triple impact. This was the one that pointed out to the world what nurses know, which is that nurses are generally undervalued and underutilised, could be contribute even more. They contribute an enormous amount, but could contribute even more if we supported them better. I'll come back to that. Next 2 in the middle row there were about things following up really the UK's contribution to health globally. The UK as a global centre for health and health science, which is what I believe we should become, and a contribution towards G7. Then coming again to new directions for mental health, the mental health workforce globally, that emphasis on mental health. And then our latest report that came out in July, which I think, I'm going to say a bit more about it, but I hope is going to be as influential as any of the others, and perhaps even more so in the longer term, because it deals with that most fundamental issue, what health workers are going to be doing in the future, and the 100 million or so health workers that there are globally, and the impact that they have, and they may have even more in the future. We've also, to complete my run around the picture, had meetings on a very wide range of topics, again influenced and linked in with THET, Myanmar health workers after the appalling coup of what is now nearly 2 years ago. But I'm not going to run through this list. You can just glance at it there and see that we've covered an awful lot of things over this period, including some things which, otherwise would never be discussed within Parliament, of things like safer anaesthesia and global surgery. And within all of that, what we're trying to do is to raise these issues in Parliament. Most of our reports, we've ended up having some kind of debate in one or other, or sometimes both of the houses, and met with ministers to discuss them. So influential in that sense, but also bringing together people like the great community around THET to discuss these issues and help influence Parliament. And that's where I hope you, Ben and Elora and colleagues, will continue in the future. Let me pick up a couple of big points. Firstly, the 3 real themes here have been about mutual learning and co-development. You'll see the links here with THET. About the UK's role in global health and how over the period this has been great, but is perhaps diminishing at the moment. And then the underlying thing that I think in the end is going to make the biggest difference here is how the health workforce develops and how they move into creating health and not just handling disease. My own work over this period has influenced and been part of this. It's been I was asked by Mr. Blair when I stood down as Chief Executive of the NHS to look at the UK's contribution to health in developing countries, as we then called countries, That was when I discovered this point about how much we in the West have to learn from people in lower income countries who don't have our resources, but also importantly don't have our baggage and our vested interests, and can think freer in many ways. And actually putting together our knowledge and knowledge of people in other countries is the way that we need to do to learn and to move forward. I moved that out into a bigger issue into sketch that out further in a book called Turning the World Upside Down 12 years ago. And then myself and my great friend Francis Omazwa edited a book for Oxford University Press called African Health Leaders. And it was really done on the premise, and if I just read from the back of the account, most accounts of health and healthcare in Africa are written by foreigners. Our book was an attempt to address the balance. It's written by Africans themselves who have led improvements in their own countries. And the book discusses the creativity, innovation, and leadership that's been involved. Now, I'm not trying to advertise the book, it was published some time ago, but really making the point, and it's still relevant today, that so much that's written about low and middle income countries is written by foreigners, and how important it is to actually hear from the people themselves who are handling these issues. That's a big theme that I have been following through in my career, and it links in very much with how I think how the APBG thinks that the UK should contribute to health globally, in the way that in the last panel session people were talking about of a degree of humility, respect, working with others to contribute to health globally. And this has been very much a sort of theme for us. We mapped out in this first report, the one with the purple cover, how the UK's footprint on health globally in a very important way is done by researchers at the London School of Hygiene and Tropical Medicine. It was used by a number of years within government. Maybe it's time to do it again in some way. But I do remember when we did it, one very senior person, in fact, it was Jeremy Farrar, director of the Wellcome Foundation, who said, maybe what you're doing, Nigel, is you're mapping the UK at its high point of influence on health globally. I hope it's not true, but the last few years we've been heading down, haven't we? And really important that we regain the ground, I think, that we've lost over that period. But let me just then pick up, before I just come to the future, the theme that we've had on the health workforce. There's somewhere between 105 and 140 million health workers globally, depending on how you count them, who you think's in that picture or not. What health workers do influences everything. What happens inside the heads of health workers, how they think about the world, is so important. Let me just pick up two of these reports. The one, Triple Impact, this is the one I mentioned earlier, which recognized the vital role that nurses have in health and in healthcare, but how much nurses are undervalued and underutilized globally. And indeed, as we discovered, how nurses are treated in countries is very much how women are treated in countries, even though nursing is not a gendered profession. But as you'll probably appreciate, I think it's something like 85% of nurses globally are women. We advocated to raise the profile and status of nursing, set up, in the end, we had 750 groups around the world in 126 countries promoting these messages, made some real impact, I believe, in 20 countries. This was a surprising spin-off from a report in Parliament, managed to persuade the World Health Organization to create 2020 as the year of the nurse and the midwife, and had some real impact around that. But that's a continuing story, and any nurse in the audience will tell you there's much more to do to enable nurses to properly work to the top of their license and have the impact that they can do. But let me just switch quickly to the final report, the one that came out in July and which we're still promoting, and I hope to talk to a minister or two about it in the next few weeks, depending, of course, on what ministers we have, and have some debate in Parliament around it. It's looking at what the future is of health workers globally, what people will be doing in 20 years' time. And it sets out what we describe as probable futures, the sort of consensus agenda, but it also sets out some radical possibilities. And top of the list there is a switch and a recognition that if we're going to tackle the social determinants of health and pick up all the wider issues that impact on health, then we need to see health workers becoming, as many do, and I think Eldred is a great example of that, people who not only do their clinical work, but are agents of change and curators of knowledge. And that's the language we're using, agents of change and curators of knowledge. If you're a single-handed psychiatrist in Bihar, you'd better make relationships with the temple and with the community if you're going to really make a difference in mental health in that area. People understand that. But it needs, I believe, to be part of how we see the role of health workers in the future, particularly as technology and AI are going to take over some of their more traditional roles in the future. So a very brief run through, quite a dynamic 11 years, I think, and some very interesting topics, and a real privilege to work with so many people on these many issues. What does the future hold? Well, I think the future of health globally, I've kept there the same top three as before: mutual learning and co-development. It's got to continue. We've got to get a new sense of global solidarity, despite all the pressures to split us apart. The UK needs to re-establish its role in global health. We need to focus on the health workforce. And of course, we need to think about how we're going to get the Sustainable Development Goals and universal health coverage back on track. We need a new focus on healthy society. And of course, we need action on emergency and pandemic preparedness. Where the APPG goes in the future, well, that's down to Dan Poulter, the chair, Elora Finlay, who's taking over as co-chair, and of course Ben and colleagues at THET. I will be a great supporter in the background and look forward very much to seeing you develop on the roots that we have built on the work that we have done over this period. And of course, I will end with an advert. Ben, I think you've advertised this for me elsewhere, that if you'd like a copy of my latest book, which is 12 years on from that first one about this is turning the world upside down again, then it's available through your website in the way that I've described. So thank you very much indeed. On that point, I will try and stop sharing, and I will try and return to the conference properly. Thank you very much.
Nigel, thank you very much. And Nigel talks about that book, Turning the World Upside Down Again, in a video that you can find in the lounge section of the conference. And yes, you can buy signed copies through us. You can also enter a competition, by the way, and try and win yourself a free copy. So check that out. Nigel, thank you very much. And may I just say, sort of personally, how pleased I am that the APPG Global Health will continue to exist. Because if we look at the richness of thinking that you've just shared with us over those 11 years, it's unfinished business, isn't it? And I'm so pleased that THET will get to play a modest part in helping to secure that legacy. I really feel very, very excited about the responsibility. It is a parliamentary group. It is not, by the way, a THET group.
Yep.
That's very important. But if we can provide modest administrative background and, and link people on this conference and the broader health partnership community to Baroness Finlay and to Dan Poulter, then I think that's for the good, isn't it, Nigel?
Oh, that convening role, I think, is really important. Pre the pandemic, we had a lot of very good meetings in Parliament where we were able to get a lot of people come in and join us and really get us to listen. Post-pandemic, of course, we're better able to use videos, aren't we?
Yeah.
And we're not going to have quite so many arguments about having to try and get visas to get people and pay for people to come across from across continents. But I do think that face-to-face convening role has been really quite powerful in help, because there isn't anywhere else that really brings together those of you working in health globally with parliamentarians. So there's potential there, and potential that I hope you and parliamentarians, supported by you, will develop.
Yes, and thank you so much. And thank you for putting together that presentation, which we'll cherish. So we're delighted that Baroness Finlay has agreed to provide the final keynote, reflecting on what Nigel's said, and of course anticipating her role as co-chair of the APPG Global Health. Elora, thank you for joining us. Those of you who don't know, Elora is a very distinguished palliative care clinician who got to know THET, I think, through your presidency of the Royal Society of Medicine. And you kindly gave us photos, which Eldred fondly showed me once upon a time. Thank you, Elora, and we very much look forward to working with you in the future.
Well, thank you so much. Can you just confirm that the sound is coming through all right? Yeah, okay. I assume that it is. Thank you. Well, I'm absolutely delighted to have been asked to take over from Nigel and feel very humbled by doing so. You can see from his speech just how much he has contributed, how much he's put in. Indeed, before he was involved in co-chairing the APPG, and I'm relieved that he will say that he'll be available to us and isn't walking away from the topic. Because his wealth of expertise is probably almost unique, actually, because he's had these important roles in the NHS and now globally, and he has phenomenal insights. So, Nigel, can I start off by an enormous thank you to you from those of us that know you, but I think also actually from around the world, for all that you've done and continue to do to contribute towards health. I thought that the video that we watched was really interesting and very important, actually. I gather, as you were very honest, in opening, you said there was some hesitancy, but I think it's really important that we know the history, because if you don't know where you've come from, you can't know where you're going to. We carry our history with us and it steers our future direction. And that was a very revealing, very touching, and in many places, very beautiful video that you showed. So I hope that that will be kept on an archive. And possibly we could think about having it, you know, on a website available, because I think it warrants watching again. Looking forwards now, obviously, I'm looking forward to taking on this co-chair role into 2003 and onwards. And we do have the UN high-level meeting in September coming up, which will be important. And of course, there will be a general election in July 2024. Now, I am an independent crossbench peer. I don't belong to a political party. And I would suggest that actually at the moment, that's a very useful position to be in, because I think it might get quite political in not always the most helpful way, whereas we can keep the voice of independence there and the bigger picture looking forwards. As has been said, I come from a background of palliative care, and I've been passionate about educating people in palliative care, palliative medicine in particular, to be leaders around the world. The course that I set up in Cardiff, the Diploma in Palliative Medicine, has educated well over 3,000 doctors in palliative medicine around the world. We have people in all continents, and there aren't that many nations now where we don't have someone who's graduated with us. The one continent we don't have is Antarctica, of course, but the patient population there is a little bit different, one could say. I have a huge concern about the next generation, though, about children in all our societies. And I think it's important to remember that there are currently 415 million children growing up in war zones. And every day, around 300 children die in war zones. And they leave behind them bereaved other children, siblings, cousins, whoever was there that witnessed their death, the trauma of it. And then on top of all those, there are those who are seriously wounded, who have suffered life-changing injuries physically, quite apart from mentally, from the trauma that they've gone through. And if we don't look to support children better, to recognize the importance of the next generation, we will be storing up problems into the future and around the world, because these children are our future. They will be the adults of the future, and they will take with them all that trauma that they have felt. So one of my very strong directions, if you like, of travel is to look at palliative and end-of-life services all around the world, where there is phenomenal waste with inappropriate treatments that aren't going to make a difference to people, where there is phenomenal under-resourcing of things that could make an enormous difference to the quality of life and the experience, the quality of life of the person who's dying and the experience of those being bereaved. We have many, many countries where there is just grossly inadequate access to even to simple analgesia. We have people going for months and months in some of these countries, in many of these countries, with overwhelming pain without being able to get pain relief. That's a scandal. When you look at the bloated map of opioid distribution around the world and see how much is in particularly North America, Australasia by comparison, and then Europe does really well, but Africa and South America do very badly. Not everywhere there, but many, many places. So I would like us to be working with the bodies that I've already been working with on a global scale about ensuring people get the care and support they need. The UK needs to stay engaged in the development goals altogether. We need development assistance, and we need to make sure that the strategic development goals are kept at the front of people's minds to be met, because the clock is ticking. 2030 is not far away. It'll be on us in no time. In the UK, we're going into next year to have the 75th year anniversary of the NHS. And I hope that what we've learnt, what we've done well, what we've done badly, can inform the direction of travel, and that we're humble enough to share the mistakes that we've made, as well as the things that we have done well, so that other people can learn from us, can develop their own healthcare systems suitable for their population, but really that overall we can look after the next generation who are coming up behind, because that's the world we will hand on to them, and we must hand on a world that's intact to them. So just to conclude, thank you again to Nigel. Thank you for the confidence that you've shown in me by asking me to take on this role. And I look forward to feedback. And I just would say to everybody involved, please give me feedback if you think I'm not on the right track. I really want to know about it, because the legacy has to be that we leave the world a better place than we came into it. Thank you.
I'm Justin Ash. I'm the chair of THET, and it falls to me to, with great pleasure, conclude what has been a fantastic two-day conference. Can I just start by thanking Lord Chris very much for that presentation, for your many years as a patron of THET, and for your co-chairing of the APPG and that remarkable list of publications which are so influential. They're a very good resource for new chairs, by the way, so thank you. And for your most recent publication of Probable Futures and Radical Possibilities. Thank you, Baroness Finlay, for that presentation, for taking over as co-chair of the APPG. Everyone looks forward to working with you, and for your welcome focus on palliative care and the next generation. I've been asked to make a few reflections on this remarkable 2 days. I feel the least qualified to do so because there have been so many remarkable interventions from colleagues with decades of experience of working in global health. And probably my biggest reflection starts with what a remarkable community it is. This conference is a community of people, both those who are presenting and those, thank you, who have attended, with this passion for global health, its challenges and its possibilities. And we've had a lot of what I was delighted by the phrase from Dr. Marion Lynch of evidence-based outrage. Well, there's a lot of evidence. There had been a presentation of statistics of the number of people who don't have access to healthcare, the lack of healthcare workers in so many countries, the size and contribution of the diaspora in the UK, the statistic that Baroness Finlay just mentioned, the 450 million children living in war-torn countries. And it's, of course, entirely appropriate to be outraged at the lack of healthcare access and the lack of access to healthcare workers. And yet what I saw was enormous positivity about the potential for joint working to tackle those issues and a real commitment to action. It was an absolute delight to see Eldred talking about his experiences. I completely agree. It's an archive of value for the future. And he talked about being responsive, not prescriptive, which of course is where the idea of health partnerships took root. And we've seen lots of examples of fantastic health partnerships. Turning the world upside down, we've seen the importance of equity in health partnerships. We've seen the importance of listening and bringing appropriate resources to them. We've seen moving patient testimonies. And I think another thing which came out was the importance of patients, the importance of communities, and very welcome, I'm sure, the integration of climate and healthcare in the agenda. So these themes have been powerful. The convening power of THET has been strong here, and I hope that debates like this will continue to flourish and be enabled. So thank you to all of you. And of course, I'd just like to conclude by thanking all the speakers, both for what they do and for their contribution. And last but not least, to Ben and to the whole team at THET who have pulled this together, the conference team. It's an astonishing achievement. I know you've worked extremely hard behind the scenes, which includes guiding tech, not terribly au fait people like me into how to get on. That's the least of the complications. So look, thank you very much. I'm sure we will share in thanking you. I hope that everyone who hasn't been able to attend will know that this is all available online. And as Ben mentioned, he's going to produce with the team a report of the themes, the thoughts, and the future, which comes out of 40 different presentations, hundreds of interventions, and many important and radical ideas. Thank you very much and enjoy the rest of your day. Goodbye, everybody.